Okay, so the attendees are going to be populating now, and we'll give everybody a few minutes to enter the room. They're already pulling in. And see already some familiar names. Welcome everybody. We're going to get started here in just a few moments. So let's have everybody just take a few seconds, log in. If you're watching us on Facebook, you are welcome to join us on the link provided above in the Zoom room. We will not be addressing questions from Facebook this evening directly. You will be able to watch streaming on Facebook, but if you want to ask any questions, you will need to join the Zoom room and register when you come on in. And we're happy to have you join us at the last moment. You can join anytime during the presentation. And you'll also have an opportunity to rewatch this meeting when it is posted to YouTube, or it will stay here on Facebook. So we'll get going in just another second here. So I'm going to stop the screen share now that everybody is here. Look, this is your team for tonight. Welcome, I'm Lisa Salberg. I am the founder and CEO of the Hypertrophic Cardiomyopathy Association, and I want to take a few moments to just introduce you to two of our team members who are here with us this evening. Julie Russo, our volunteer coordinator, and Valerie Ventry, our Center of Excellence coordinator, who along with Amy Mann and the rest of our HCMA team have helped to make these meetings possible. And an early shout out to our sponsors to thank Myocardia, Cytokinetics, Boston Scientific, and Invitae for their funding of this endeavor, which was supposed to be an in-person meeting. And in March of 2020, we pivoted to virtual, and we will remain in a virtual status through the end of 2021 at least, bringing you additional episodes of the Bighearted Warrior Tour. So without further ado, I'm going to turn the night over to Steve Almond, Dr. Steve Almond from the Mayo Clinic, and he'll tell us a little bit about his team and tell us what we're going to do tonight, and then I'll talk to you in a minute.
All right, thanks, Lisa. Yeah, it's a shame we can't get together like we did in the old days. Maybe again someday. To all of you who are joining the webinar, the webcast, welcome. I hope you'll find tonight an interesting discussion. From the Mayo team, we have with us tonight, in the order they're appearing on my screen, Jane Linderbaum, who is an Uber nurse practitioner who has been running the cardiology practice at Mayo for a number of years, but also is one of the key cogs that makes our hypertrophic cardiomyopathy clinic work. Dr. Says Daryl, he goes by Brian Newman, is another one of the cardiologists on our team, and Dr. Jeff Geske, who's been a member of our team as well, who also is in charge of most of our research activities within the HCM world now. And so we will each have some things to share with you this evening, but at the moment, I'm going to hand it back over to Lisa as she's going to talk to you about the Hypertrophic Cardiomyopathy Association.
Thank you, Steve. I'm going to do a screen share right now, and we're going to go through a couple of slides, talk a little bit about what's going on at the HCMA and where we're going in the future and some of the programs that we offer. So just again, this is the agenda for tonight, and these are our sponsors. And again, we could not do half of the things that we do without sponsors and support from the members and donors to the organization. So we thank you for that. This is our last meeting for 2020. We made it through, and if you're here today, you did too. 2021 might still be a little bit complicated, but we're going to get through it together, and we have some new programs that are actually going to help you during these crazy times of COVID and being isolated and dealing with a chronic illness. So we'll talk a little bit about that later. So many of you who are here tonight have been through a journey to get to a diagnosis of HCM in and of itself. You were told you had an athletically induced asthma, regular old asthma, you had an innocent heart murmur, you had mitral valve prolapse, you had all these other things, but they didn't quite get to the HCM thing until they did. And then things start to make more sense. So we want to just acknowledge that we know you've been on a journey, and we know that the journey with HCM can be long and somewhat challenging. So we're here to support you through that endeavor, and we're going to learn a lot more about how we can do that. So we first want to make sure we're talking all about the same disease, and that's why the Center of Excellence concept is one of the pinnacle points that we try to bring home to people to go to high volume care, because many people are told they have HCM because they just have a thick heart. But there's a lot of, oops, I popped it all in together. Oh, sorry. jumping around on my screen here. So there's lots of different reasons why people's hearts get thick. And some of them are sarcomeric mutations, and we know some of those. Some of those we can't find a gene yet, but some of them are non-sarcomeric mutations and may fall under different pathways of disease, which might have their own treatments or their therapies or other diagnostics that are needed. So I think it's really important that everybody who thinks they have HCM go to an expert who can actually determine why your heart is thick and why you have this anatomy. So that's a critical starting point. We know in HCM there's different pathways that your disease may go. A lot of you will say in this asymptomatic, low risk, but you're gene positive and a very stable course. Some people might feel well, but they're at high risk for sudden death. Others will have progressive heart failure due to obstruction. Others will have heart failure without obstruction. Some of you will have AFib and stroke. And at the end of my talk, which I was supposed to do at the beginning of my talk, I'm going to put up a poll and you're going to tell us a little bit about who you are. Julie, if you can launch the poll, maybe that would be good. I'm not sure if you can or not. If you can, launch the poll and you guys can take the questions while I'm talking. We know each one of these pathways have treatments and therapies, but picking the right one for the right person is a very complicated prospect for some local cardiologists. And that's again why centers of excellence matter. There you go. You got the polling. You guys can do a little side work while I'm talking. So we did a little bit of work earlier this year with the American College of Cardiology, and I was asked to present on why centers of excellence matter and why high volume care matters. So we pulled together some data. The average cardiologist in the United States sees about 2,000 patients in their entire practice, which means they probably see about 10 patients with HCM. Maybe they realize it or maybe they don't. But out of all those pathways that you can have for HCM, what is the chance that a local cardiologist has ever seen anybody just like you? Probably not a really good chance. So we want to make sure that you get to a high volume pathway where they can figure out what bucket you belong in an appropriate way. I don't know why my slides are being wonky tonight. There we go. 20% of you or so may land in this bucket versus 70% will have some progressive heart failure or symptoms related to obstruction. And 20% might be non-obstructed and have symptoms, and 20% might have AFib or be at risk of stroke. So it's really critical that we know where you land. And many, many years ago, and I can go back, and I love doing this when I'm talking to a different center. Can remember the very first summit, I sat next to Gordon Danielson, who introduced me to Joe Duraney, both cardiac surgeons at the Mayo Clinic. And that was how my relationship with the Mayo Clinic actually was formalized. We had done some telephone work beforehand, and we had referred a number of patients specifically from Canada for myectomy. They couldn't get a myectomy in Canada in the mid-90s. And that's kind of where our relationship started there all those years ago. We didn't use the word center of excellence. We just knew they were trusted sources of quality care for patients with HCM. And over the years, I'm very happy to say, 25 years this February, believe it or not. Yes, Steve, we're that old. You know, well, we were the young ones then, and we're not anymore. But we've now developed 41 HCMA recognized centers of excellence. And this is a care model that we know suits the needs of those with HCM and has the type of volume, specialists, and infrastructure to be able to take care of all of the needs of somebody with HCM, which could float throughout different subspecialties within cardiology. And it can include things out of cardiology, including orthopedic, maternal fetal health, and all the other things that are you. So we know that centers are structured slightly differently, case to case. And we know that some of them don't have surgery and don't have transplant, but they have referral relationships with other programs. So if you want to see a full directory, you can go to 4hcm.org, and there's a full directory listing there, and you can find where these programs are and how to contact them. We currently have 9 programs under review, which has become challenging in COVID times because resources in hospitals are limited right now. So we hope by the end of 2021, we can figure out a way to do virtual site visits and really get these newer programs engaged. And we have some other programs that I do have to talk to you about, Steve, that we're going to be working on to help develop these new centers in a very cohesive manner. So
what is it going to visit Hawaii?
What's the matter?
Let me know when you're going to the Hawaii site visit.
Oh, there might be some work involved before I let you do that one with me, but we'll work on that. Yeah, that was a great phone call because we actually have a lot of people in the Pacific Rim that don't have any place to go. And if they can get to Hawaii, that would be really helpful for them. So this is my fun slide. This is the way I can explain in a visual way what HCM patients go through or what we feel like we go through when we're getting through a system. So we know, I don't know what happened with all my slides today. They're all a little bit off. Something weird happened. So a patient with HCM goes to a hocomologist, and I thank Dr. Harry Lever for that terminology. We just love it. So these are people who really specialize their practices in understanding HCM at a very deep level. And they're going to be the gatekeeper person for the patient experience. And these patients are going to go through imaging and electrophysiology workups and heart failure workups and genetics and maybe mental health assessments. And they're going to land in other buckets for a period of time. But when their care in that space is done, it's really important that the majority of people go back to the hocomologist or the HCM core doctor. And when they do that, we make sure that there's continuity in the care. Sometimes people with HCM who are having atrial fibrillation, as an example, might go off to electrophysiology for a while to be managed under there. If they stay there, sometimes other things that are going to happen to the heart can't be found as quickly as they could have been if somebody from an imaging background or a heart failure background were involved in that care. So it's really important that this is a cohesive team approach. So we make sure patients get the right care at the right time, at the right level, and know an appropriate testing. So we know that there are different models, and this is the only part of the guidelines that I saw before the guidelines, but I had approval to do that, is this comprehensive center of excellence concept versus a primary care or your primary HCM center. So there's 3 different buckets here. I've taken the opportunity to take the HCMA's perspective of what we feel by the stars based on patient experience. If you want the best care and you don't want to have to go anywhere else, a comprehensive HCM program that can go from diagnostics to transplant and everything in between is probably your best step. However, not everybody needs that. And there are smaller centers that might not have surgery and might not have transplant, but are excellent for management, imaging, follow-up, device replacements, and you can do most of your work with these programs. Some of the work needs to be done with your primary cardiologist, and I cannot state strongly enough how critical it is to have a primary cardiologist in your hometown. If you have a crisis, you can't always get Steve Alman on the phone or Jeff Getsky on the phone to talk to you at 3 o'clock in the morning when you're having an onset of new symptoms. You need your local cardiologist to be a partner in your care with your center of excellence partners as well. So there's plenty of room for everybody at the table here, and it's really important that all the players are at the table. Not every patient needs every service, and you can choose which services you want, need, and where to go for them. And we also know that there are some insurance restrictions that are not going to allow patients to constantly be seen at certain centers, either because of coverage issues or distance. So we need to make sure that as many patients as possible have access to the highest level of care possible, and that on top of that, what you don't see every day is the amazing network of support between centers and collaboration and willingness to consult on complicated cases. I have never in 25 years had a specialist at any center say, I'm not going to waste my time talking about that complex case with you. They dig in, we all want to find answers together. So it's a great community of experts and nurses and practitioners and perfusionists, and you name it, they have fantastic teams. So we want to make sure that people have access to that. What do we know about the patient's perspective of Center of Excellence care? We've done lots of surveys on this. We've asked for feedback over the years many times, and we know that patients feel that their care at a Center of Excellence has higher quality. They feel improved quality of life. They have improved mental health. They feel understood. They feel heard. And sometimes for the first time in maybe 20, 30 years of complaining about subtle symptoms, they finally have answers. We also know that they have lower complication rates. Now, this is from the patient's perspective than having procedures done in a lower volume center. We know this because unfortunately we hear the tragedies and horror stories from patients who are seen in low volume centers, and they finally get to a high volume center and they have really good outcomes. We also know that patients like to be involved in clinical trials and research, and they want the opportunity to be able to engage in that way. So they like the experience better. What do we know very clearly from the data? We know that mortality rates are better. And we have, what is it, like 99.7% survival rate for myectomy and these crazy high good numbers. But when you go out to a community-based hospital, I believe it's the numbers 1 in 8 ends very poorly when it comes to surgical outcomes. We know that patients are likely to be treated with the appropriate level of testing and medication and therapies and not over-treated or over-tested. And we know that oftentimes they're taken off of therapies that are contraindicated or just not appropriate for their diagnosis when they get to the high volume care models. So that is my pitch for why we believe in high volume centers of excellence. I want to talk for a few moments today about some of our programs and how you as patients can get involved. We have obviously our Facebook page. Many of you are watching right now on the Facebook page. We stream events like this through the main page, but we also have conversation groups that are moderated by volunteers, and in which you can get a great deal of information and support and venting opportunities for when you need them. This is a patient-only group. We do have a couple of doctors in the background who are there as volunteers for us, and the rest are trained volunteers from the HCMA that are assisting in guiding your care and providing insight along the way. I will tell you that we're building out a couple of international programs here. I'm kind of cloning myself in different countries. I'm speaking all kinds of different languages now. Our first group that we're going to be launching is actually from Sweden. So there'll be a Swedish speaking group with Swedish moderators that will be anchored to the HCMA page, and then you'll have separate groups for each country. We have a number of countries coming up, and hopefully by 2022, you'll see a nice array of different countries where you can speak about HCM in your native language. That's going to be called HCMAI, just international. So stay tuned for that. We have our online support group programs, and I'm very happy to say we actually had our first meeting this week. And today, we met all of our support group leaders, and we decided on final themes and first topic points for their first few meetings. Get ready for getting inundated with online support groups. We will be running over 20 groups per month, with the opportunity of over 500 engagements with our numbers that we're going to be pushing, no more than 25 per group. We have lawyers, we have writers, we have all kinds of interesting people, kindergarten teachers, and amazing people who have experienced HCM from so many points of view. We're going to be having groups discussing family issues related to HCM communication, sharing information, pre-myectomy, post-myectomy, ICD groups. They're all going to be there for you to participate in. You're going to have to sign up to get the link to join. We will be having special guests, and hopefully some of our friends here from Mayo Clinic will join us in some of these groups to give smaller talks to smaller groups. Over the year, they'll get their invite soon, hint, hint. And we will get you guys all involved. We are going to bring this community together in ways that we never thought possible. And these conversations not only help the patients, but I go back to the first days of the first meetings of the HCMA where Barry Marion sat there with his notepad taking notes saying, these are really great questions I don't know the answers to. It's a collaborative relationship that we hope to build there as well. Okay, so Q2 next year, we're going to build our peer-to-peer big-hearted support group system, which is going to be like the eHarmony of HCM. You'll take a survey, tell us what you're looking for. The other person will take a survey, and we'll try to match people based on experiences and what's important to you. And we don't know that these are going to be one-off conversations, a month, a year, a lifetime, a meaningful friendship. We don't know, but we want to make sure that people can communicate on the levels that they want. Some people are not group support groups people. Some people want that one-on-one communication. We want to provide all of these opportunities, and we're going to keep an eye on the back end of the system, make sure everybody's happy. If there's any problems, we'll help work them out. So that will come up Q2. The Share Your Story program. We have the Tales from the Heart podcast. We've been using that more for medical education this far. We're going to be using it for other things coming up in the next year about patient journeys and experiences. But you can also participate, and I'm specifically doing a call out today for people from communities of color with HCM. We're building up a library of patient experiences for our new website, which will launch the beginning of next year. And each patient is going to tell their story from their point of view. So physicians, if you have patients of color who might want to participate, we're a little light-skinned in the HCMA repository of information, and it's really critical that we show all faces of HCM. So it's really important that we get them involved. So if you want to get involved, email us and we'll give you the contact information at the end. to have that. We have our legislative subcommittee that we have been working very hard to build the framework for a program that's going to move forward in the next year. We wanted to wait till this election cycle ended before we got involved with anything political. You can imagine why. But this is state level legislation that we're looking to move the needle on. We are looking to do what we've done in New Jersey, and that is the inclusion of a cardiac screening in the well child exam. So we can have the opportunity very early on to look for family history of heart disease or early symptoms, heart murmurs, and make sure that they get worked up properly. It's our opportunity not only to find the child who might have a problem, but the family who has a problem. There are other initiatives that we'll get involved with. Obviously, good AED, CPR, Good Samaritan coverage. If we have the opportunity to engage lawmakers on a state level on those issues, we will. And then we're also going to be working very closely with the FDA, CDC, and other federal agencies on matters of importance to the HCMA. I just got off of a meeting today. I'll pick some brains later about the question of patenting specific genetic mutations. It's heading back to a Senate bill again. It went to the Supreme Court. It's back in the legislature to determine whether or not your individual personal genetic mutation can be patented and owned by somebody else. It's a very interesting philosophical question, and we're going to weigh in on that from the patient perspective. What else do we have here? So for those of you who participated in our patient-focused drug development meeting, thank you. I'm very happy to tell you that our Voice of the Patient report was submitted last Friday to the FDA, and I was told it was going to take 30 to 60 days to review, and they would get back to us when we could pretty it up and send our final copy, and they told us not to format it yet. Sent it in on Friday. Monday afternoon, I got an email telling us it was a fantastic report. They had no edits. And by the way, that hadn't happened to them before. So bravo to our team who helped write that report. It was fabulous. There is a draft form on the website right now. And I will be circulating the final prettied up copy to all of the stakeholders on our email list. It'll be a special email, and it'll go out to all of our Center of Excellence partners as well. It was a phenomenal experience working directly with the FDA. We are at the table. They are listening. We want to help them in any way they can to bring good drugs to market that are going to help the community and devices as well. If you have not had the opportunity to watch the meeting, I encourage you to do so. You can kind of fast forward through, see some amazing patient stories, hear some really amazing life experiences and hopes and dreams for the future of HCM. So I'd encourage you to do that. I want to remind everybody that all members of the HCMA are eligible to receive a free 23andMe ancestry and health screening kit. There are no strings attached to it. It was a gift in kind from Myocardia, who through a business arrangement got it from 23andMe. They gave it to us to disseminate. So you can claim one. Our speakers are welcome to do so as well if they would like. All you have to do is go into the HCMA store, put it in your basket. We'll do a confirmation. If you're a member, you get it for free. That was the stipulation of the agreement. So we welcome you to do that and remind you that Invitae's free genetic testing panel is still available, and you can get that through the front page of the website as well. We want to thank our friends of many, many years at the Mayo Clinic, although some of you are kind of new to me, but our relationship has been going on a long time, and we hope that it continues to be as mutually beneficial in the years ahead. We thank all of our Center of Excellence partners, our staff, our volunteers, and of course, I always have to thank Brandy, who is my donor. That's all I know about her is her name, because without her and her family making the decision to give life, I wouldn't still be here with you today. So thank you to Brandy. Thank you to everybody. And I'm going to hand the screen over to our next speaker. And before we do that, I'm going to pull down the poll to finish the poll. We'll go over the poll results. And remember, you can use the Q&A feature during the talk, and we will try to answer them. Our faculty are welcome to answer the questions as they come up, or we will hold them till the end and we will answer them at the end of the evening. So I'm going to end the poll, and I'm going to tell you that we have a wide variety of locations today. I'm going to share the results. Most of you from the Northeast. Midwest is coming in second, but we got the whole country pretty much handled. And somebody's from someplace other than those listed. You'll have to write in where you're from. You've got me curious. Most people here, 81%, are patients. Some of them are patients and also family members. Some of them are just family members. And nobody's just curious and no medical professionals so far this evening. So have your family members or you had any of the following? So a few of them are newly diagnosed, so just 10%. 74% are taking meds. 42% have ICD, so it's an ICD heavy group. 35% have had their alcohol septal ablation or myectomy already. 45% have AFib. 23% of us have lost a family member. 6% of us have had transplants. I'm not in there, so statistically we're doing quite well tonight, transplant folks. 68% have had genetic testing. That may be the highest so far out of all the meetings. Actually 16% are considering to get an ICD but haven't done so yet. Hoping maybe we can help them in their decision making this evening. 13% are looking at septal reduction therapies and haven't made their choice and commitment yet. So that gives you an idea of kind of who we're talking to and about tonight. I thank you all for participating in the poll. I know you all didn't do it, so there's some other data out there. And we are going to pivot now to, I guess, Steve, you're up next, right?
I think that was the game plan.
Oh, no, Jane's up next.
Oh, Jane's next. Okay.
Jane's next. I got to keep my calendar or my agenda over here. I'll mess it up. So Jane, if you want to do a screen share and I hand it off to you.
Okay, can you see me okay?
We got you. Great. Thank you.
Okay, great. Thank you, Lisa. Some great work's been done by Julie and Valerie and your entire team. And thank you for the kind invitation. I'm really pleased to be here. Your nice intro actually did a nice setup for me. I think I'm going to agree with everything that you said, and probably we can go through some of this kind of quickly. All right. So my job was to give a little quick overview before my colleague experts come on and talk with us in more specifics. But I'm going to talk a little bit about what's unique at the Mayo Clinic, and certainly what's unique about our hypertrophic cardiomyopathy program at the Mayo Clinic and our integrated program with patients and families and individuals at Mayo Clinic. So first of all, it's important to understand the vision at Mayo really is to contribute to the health and well-being, providing every patient the best care every day in our integrated system of clinical practice, education, and research. And importantly, the needs of the patient come first, which is pretty fantastic to hear when you're the patient. So the Mayo Clinic model of care sounds really contemporary and new and bright and shiny, and teamwork and collaboration is important. And we know that it's important that you're able to go seamlessly between your primary community cardiologist, your center of excellence, and your HOCM center. And certainly it's not new. In fact, way back 150 years ago, Will and Charlie Mayo, who founded the Mayo Clinic, were really pioneers in medicine as a generalist and a surgeon. And Dr. Will Mayo said it's really necessary. Can you imagine saying way back then that we need a team of experts and we need a team of individuals that can cooperate to optimize care for patients? And we're going to need lots of different specialties, and they're going to really need to work really well together to provide the best care for the best outcome for each individual patient. So Mayo Clinic is the first and largest integrated multi-specialty practice. So we have multiple subspecialists and specialists under one roof. It's not for profit, and we're a worldwide leader in patient care, education, and research. And you'll hear that probably as a theme throughout most of our talks. We talk about the three shields: education, practice, and research. We're a globally recognized brand and over 5,000 physician scientists across every specialty and treating over 1 million patients worldwide annually. So at the Mayo Clinic, again, three shields. Patient care is the largest of the shield, and we also have education and research. Most of our clinicians, most of our physicians and experts have a role in all three shields. There's three main campuses and lots of smaller satellite campuses. Bottom left-hand corner, Rochester, Minnesota, that was the original and the largest of the sites. We're also in Jacksonville, Florida, and then in Phoenix, and the hospitals in Scottsdale, clinics in Phoenix. And of course, they don't have any snow there, and we've got all the snow in Rochester, unfortunately. Keep in mind, we've got a large educational program, both a medical school, fellowship programs, and a large contingency of allied health programs as well, training professionals and experts to provide care. We continue to be ranked #1 in our hospitals across Arizona, Florida, and Minnesota. in the annual US News. So important for this group, and what you're really here to hear, is what's unique about Mayo Clinic for hypertrophic cardiomyopathy. And when you think about the care of a patient with hypertrophic cardiomyopathy, each patient has individual needs, and to have all of that available for you in one center under one roof, where in fact it can be utilized throughout care decisions on an ongoing basis, and where in fact those subspecialty experts talk to each other to provide the best outcome for the patient. And certainly central to that is the priorities of the patient. So certainly the timing and the shared decision-making with the patient regarding what are your priorities for your care and how we can help you meet or exceed them. I always say that our job at the Mayo Clinic is to exceed your expectations as a patient. That may be both in delivery and care, might be in education, it might be in the research that's available to you. There's multiple ways for us to do that. So the needs of the patient do continue to come first. And at Mayo Clinic, there's guiding principles under which we all work. And if you cannot work in those guiding principles, it's unlikely that you're going to continue to thrive in the Mayo culture. So we are really trained and expected to work closely and interact with each other in a professional, respectful fashion on an ongoing basis throughout our entire careers. Most are involved in education, practice, and research. Certainly there's opportunities in quality projects, innovation, and care. But the culture of Mayo Clinic really is that there's ongoing discussions and collaboration on care decisions. Nobody's expected to make independent decisions, and we all know that decisions are actually better when we have 3 experts together collaborating on a condition. And certainly as things change and research developments are made, these things will change over time. When we think about hypertrophic cardiomyopathy and optimizing the care for the patient, at the Mayo Clinic, you really have one physician who helps coordinate your care. So for example, if Dr. Amman is my cardiologist and I have hypertrophic cardiomyopathy, I would recognize him as rather the quarterback of my care, and he would be my point person for contact. He might have multiple supportive members on his team and other cardiologists who might discuss cases with him, but the specialists and the collaborating experts, electrophysiologists, the geneticists would all be on his team. They would support and coordinate care and have ongoing discussions with you. The hope too is that we do this similarly across our practice. So at any point in time, if Dr. Amman would not be available, one of his colleagues could pick up that care in the same consistent fashion that Dr. Amman would do that. We definitely want to individualize the care for each patient. And when you look at this physician in the top of the corner, he's thinking pretty hard here. So I hope he's got colleagues to collaborate with if he's making a difficult decision. But if you're the patient, you really want things like your personal priorities and symptoms taken into consideration. And you really want presented to you the best available options based on today's data and on the center of excellence and the outcomes. And certainly you want to be treated by the person who has seen the most patients with my condition in my age group, who has my symptoms, and what is the data for the outcomes in patients like me in your practice. And I think that's helpful and reassuring information for optimized decision-making. Here's an example where at Mayo Clinic, Dr. Amman led a team to really work with his colleagues to develop the best practice for hypertrophic cardiomyopathy. That helps us quickly standardize what we think is best. It helps guide decision-making. It helps optimize testing and decrease costs for our patients. This is available to all of our team members and certainly helps us with expediting itineraries for care for our patients also. So at Mayo Clinic, we are a center for excellence, and that's definitely worldwide recognized. We have 5 cardiologists who really spend their career specializing in hypertrophic cardiomyopathy and 2 surgeons. There's a dedicated team of nurses and dedicated scheduling specialists, all who work together to create an excellent experience and good outcomes for our patients. You can see we see over 500 patients a year with hypertrophic cardiomyopathy and have the benefit of the subspecialty clinics at our fingertips. The scheduling, the patient flow, the communication, and the camaraderie amongst these team members is apparent. Most patients say it's difficult to describe, and they would encourage other patients to experience how different that is. We talked about this individuals and the specialists under all one roof. All of these individuals are on your team and available. So they're certainly dedicated to the individualized care of the patient and the patient experience. So the hypertrophic cardiomyopathy team has a really close relationship with all team members and are knowledgeable about the ongoing clinical trials that Dr. Geske will talk with you about. There's a group of geneticists that work closely with Dr. Amman and the team and provide excellent counseling for our patients in making those decisions. There's social workers, nurses, and pharmacists available specific to this diagnosis as well. This actually, Lisa talked about most of this, so thank you, Lisa, for that nice kick up here. But as we think about where the opportunity is and where our successes are, certainly as Mayo Clinic employees, we become empowered and highly satisfied employees and providers of medical care. Our patient satisfaction in the hypertrophic cardiomyopathy practice under Dr. Amman's leadership has won sort of the Mayo Clinic Award for optimized patient satisfaction on an ongoing basis for quite a few years now in the running. We have excellent surgical outcomes, certainly due to our high volume center, and our patients actually achieve a high quality of life and meet their goals with some of their treatments. We know that with our dedicated team, we increase the efficiency of both the episodic care for the patient and certainly the recovery of the patient after a treatment. So in summary, I've talked with you about hypertrophic cardiomyopathy and what's unique about Mayo. Much of the uniqueness isn't new. It started 150 years ago. But in our contemporary environment, with our ever-changing research discoveries, this will continue to evolve and continue to improve. And in summary, the best interest of the patient is the only interest to be considered. And in order that the sick may have benefit of advancing knowledge, the union of forces is necessary, which is an excellent kickoff into our integrated team and our integrated practice. So I think we're keeping the questions to the panel. Is that correct, Lisa?
That is correct.
Okay, so I'll just give you a little foreshadow of what's coming up, and then I'm going to hand off actually to Dr. Amman. But very quickly, Dr. O'Brien Newman will talk with us about myectomies and the differences between the apical and the transaortic approach. Dr. Newman is an assistant professor, and he has special interests in hypertrophic cardiomyopathy, Fabry's, LV non-compaction, and arrhythmiogenic cardiomyopathy. Following Dr. Newman will be Dr. Geske. I'm sorry, he'll follow at the end, but he's going to talk to us about research, and he's also going to give us clues on how you can be seen at Mayo Clinic if you're interested. Dr. Geske is an expert educator and also an assistant professor and a consultant in our department. He has interests in hypertrophic cardiomyopathy, and he is specialty multimodality imaging. He's interested in research and certainly invasive and non-invasive hemodynamics and left ventricular outflow obstruction. And finally, Dr. Amman, who actually leads our hypertrophic cardiomyopathy, and we're very proud and privileged that he led the most recent guideline writing, and that's a pretty heavy lift, so we're very happy that he participated in that and proud of that work. Dr. Amman's a professor of medicine, the director of the clinic, and he's actually the Associate Dean for our Center for Connected Care, so has led much of our efforts on video visits and virtual visits and really helped us certainly through the pandemic and staying connected with patients. But today he's going to talk to us about the new hypertrophic cardiomyopathy guidelines and what should I know. Dr. Amman.
All right. Well, thanks, Jane. That was a great overview of kind of the culture of Mayo Clinic. And I've looked at the participants and seen many familiar names of people that have been there and probably can attest to some of those attributes. So thank you so much for doing that. Let me see, I'm gonna put up a slide here. I will talk about the guidelines. As you may know, they just got published on November 20th. It was quite a process. It was about 2 years. I had over 4,000 inbound emails in order to get this done. And what I thought I would do for the purposes of tonight is not spend a lot of time with tons and tons of slides, but just talk about the key kind of points that are maybe new or refined in this version of the guidelines, and then let Lisa ping me with the questions that she's had from the communities she's been talking about as well, so we can make sure we can get those questions answered. So I'll run through these, and we're gonna double back and focus on in more detail on some of them. So, you know, there's a top 10 messages at the beginning of the documents, and the very first one is a focus on shared decision making, and we'll definitely come back to that as we're talking tonight about what that means and what that doesn't mean. But it puts the patient first in decisions around their care. It helps them be informed and participate in those decisions. As Lisa and Jane both pointed out, the concept of high volume expert centers, we all feel really strongly about. And this is the first guideline document, not just the first HCM guideline document, but the first guideline document that got centers into it. And we were cautioned that it might not fly. There's political reasons why it might not fly. It looks self-serving for the academic cardiologists who sit in these committees to say you should be sending the patients to high volume centers, but yet the data that, like Lisa showed, data have been published that the differences in success rates and lack of success rates are so dramatically different that the peer reviewers and the Joint Steering Committee for the guidelines felt that we did a good job of addressing that. And so we're glad that we get to talk about that. And exactly what Lisa said is, how do you continue to have a multi-party team that includes your cardiologist at home, who has to be a part of your care, and have an established referral dialogue between the patient and his expert cardiologist, local cardiologists, and keep that going. And that's one of the key points. We did some refinement of family screening, particularly kind of what to do with younger kiddos. And this time on the guidelines, we actually had more pediatric cardiologists as part of the writing group. So we did get some more definition for the younger people. And so we talked about genetic testing and when you start screening. Cardiac imaging is not new to hypertrophic cardiomyopathy, of course, but we were more specific in when, for instance, MRI is needed and how you use that, in which places in therapy or decision-making you might use that. Sudden cardiac death risk assessment is something I know that Lisa wants us to go back over some more, and I think that's an important concept. This is, you know, the most feared aspect of this condition, and how we assess an individual's risk and help them decide whether or not they want to have a defibrillator placed is an evolving science, and we learn more about it year after year, and so we'll talk about that. And in particular, in this guideline, we also talked about how you risk stratify children, which is different than risk stratifying adults. And the decision to put a device in a small-bodied individual who's going to grow is also a different set of risks to having a device placed. So that's an important concept. The use of myectomy and ablation is re-emphasized, including some indications that you might want to proceed to particularly surgery earlier if there are other high-risk features about an individual patient's status. And so we added that. Atrial fibrillation is discussed, and particularly the need to prevent stroke in atrial fibrillation. So patients who have HCM and atrial fibrillation have a higher risk of stroke than the general population of atrial fibrillation patients. So we really think it's important to help them prevent getting strokes. We kind of dovetailed our advice on how you manage advanced heart failure with the heart failure guidelines. And then another important aspect is what we talk to our patients about in terms of healthy activities, exercise, and competitive athletics. So Lisa, maybe I will pause at that point and let you prod me with your priority questions from that list of the top 10 take-home messages.
Somehow I think that Steve's going to regret this. No, only kidding.
Yeah.
Okay, so some of the areas of confusion, and people have already come back to me and said, you know, I got an ICD put in 10 years ago for these indications. They don't seem to be as important anymore. Can you discuss how we have evolved in our understanding of risk factors, and if there were any topics that were brought up that were evaluated to maybe be added as a risk factor and didn't quite meet the mark yet? Or can you explain a little bit about how the process went, including ESC risk score versus US-based 1, 2, 3 risk factor, and how that all kind of worked out?
Yeah, so I mean, the issue is that the science behind each of the risk factors, we learn more about it each year. So if you go back 25, 30 years ago, and Barry Marin was doing all of the work in HCM, and there was a few other places writing about stuff. Well, you only get so many patients. And now that we've got more and more centers doing research, it makes the statistical conclusions that you can derive about the strength of a risk factor stronger. And so the fact that we have more collaborative research going on, pooling our patients, the more patients you have, the more certain you can be about how strong a certain risk factor is. And that's why someone who had a defibrillator put in 15 years ago for risk factor X might not see that on the guidelines. And that doesn't mean it has no relationship to sudden cardiac death and that they have a misplaced defibrillator. It just means that, that it's a different discussion now than it was, and we know more. We've added more risk factors, in fact. The discussion about the individual risk factors really was science-led. It involved specific systematic review of the literature and assessment of each of the risk factors on its scientific merit. We also looked at one of the missions in the guideline is try to evolve the prior one, unless there are such definitive data that it needs to be thrown out and blown up and start from scratch. And so you'll notice that the risk factors, the idea of massive hypertrophy, family history, arrhythmogenic syncope, were all in the 2010 version. They're in the 2020 version as well, because they have strong data behind them. But it was a long discussion, debate amongst the writing committee members about which ones maybe carry more weight, which ones maybe carry less weight. We talked about how you might stratify them in different groups. We debated whether the risks for children should be a completely separate topic or try to lump it in with adults in the same one. And you can see we kind of hedged our bets, can put separate paragraphs in the supporting text for that. The biggest debate over the past 5 years has been how you incorporate the ESC risk calculator. And the way we handled that is, I actually think that it's fairly intuitive if you step away from the passion of the arguments. And that is, think about anyone who had surgery. At some point you sat with a surgeon and a surgeon said to you, you know what, you're a little bit higher risk for this operation. It's probably 5% for you. And the patient said, okay, I'd rather feel better. I can risk that 5%. Another patient might have said, wow, that's too high. I don't want to have that operation. That's the best way to use risk estimates, is to help a patient understand, if I tell you you've got a risk factor, most of my patients have said to me, well, how high is my risk? And that risk tool gives us a way to tell you how high your risk is. As Lisa knows from the myriad of phone calls you take every day, most patients, when they first hear they got HCM, they think they're likely to experience sudden cardiac death. And we can use this tool to help people understand, yes, you have some risk, but it's not likely to happen actually in anyone. But some patients are higher risk, and this is how high that risk is. And each patient then has their own way of doing that. The ESC used hard cutoff points in theirs to say if you had less than a certain percent, a defibrillator probably wasn't necessary, and more than a certain percent, you should get a defibrillator. We felt like that takes the decision-making away from the patient and is too dogmatic. And so again, if you are someone who is the primary or only financial support for your family and you have HCM and someone tells you you have a 3.5% chance of dying suddenly in the next 4 years with your risk factor, likely you're going to choose to get a defibrillator because of your life circumstances. If you're a completely different patient who, for whatever circumstances, doesn't have young kids at home or are financially independent, you have faith-based reasons for not wanting man-made devices, et cetera, you're going to hear that percent and say, well, that sounds like a 96% chance nothing is going to happen to me, and I'm okay with that. And that's the concept of sharing with a patient that they have a risk marker, what the magnitude of that risk is, and then they can share with us what their goals are and what they're seeking to get out of this and whether they want to pursue a defibrillator or not. So there's no hard and fast, you must get a defibrillator if you have massive hypertrophy or something like that. And so that's the way we blended it together. We felt like that was the best way to share with patients, just like surgeons have been doing for years when they share risk.
I want to stay here for a minute
Yeah.
because we've done so much. If we think of where we were 25 years ago and understanding risk and where we are today, we have evolved so much. But we know that we can never say somebody's at zero risk.
Right.
That doesn't exist.
Right.
So there's always a little bit of a risk, but there are cases where the little bit of risk, and then there's this other risk we haven't talked about yet, the risk of the device.
Yeah.
The risk of life with the device and the replacements and the
Yeah.
leads, which I'm going to ask Brian later on some of the device issues with some of the recalls that are out now. So things happen. How are we working this shared decision making, low risk, risk of device? We know these are complicated areas, but can you tell us a little bit about some of the thought that went behind these questions?
Yeah, so great question. So again, putting in a defibrillator is also not a zero risk proposition, as Lisa is saying. There's a small procedural risk having that put in. Now it's not death, it's infection, it's complications for the incision site and those types of things, but it can be complications. And I have had patients who have had lots of inappropriate shocks, who have asked to have their devices subsequently turned off because it was totally decreasing the quality of their life. And those are part of the discussion that you have to have with a patient before you put in a defibrillator, as you're talking about the risk. It's the risk of not getting a defibrillator and the risks and benefits of getting a defibrillator. And that's all part of the discussion. What is in this guideline is more advice about trying to, if you're going to get a transvenous ICD, so one that's placed up here in the top of the chest with a lead that goes through the veins and actually touches the heart, minimizing the number of leads that we put in there to minimize the amount of exposure to blood and infection, et cetera. But we also talk about the subcutaneous ICD and that it does have a role in HCM, but that's also a personal decision for each patient. Some of whom are eligible for those newer devices and some people aren't because of electrocardiographic quirks about their ECG. So that's all part of that discussion. So these are, as you know, these are all long discussions about whether you do this. And usually, if you see one of us in the HCM clinic and we have this discussion with you about the devices, you will then also see an implanting electrophysiologist who will go back over all of the logistics about the devices themselves. And so you get multiple discussions about an ICD from two different points of view at that point. So we help you make the decision, yes or no. And once yes, then we have the implanting physician also go over all the intricacies of the different devices.
And they can be complicated issues, and you may want one device, but it may not work for you. You may have a bad threat, bad window. It's just not going to work. So sometimes you don't get as many choices as you want. So I'm going to take a little bit more of our time, and then we're going to go back to agenda, and then we're going to come back to some Q&A, which some of them will come back to this issue. But the concept of shared decision-making is wonderful and noble, and it's really how medicine should be practiced in my view. But it's a real challenge to find the time in a busy practice to make sure patients really understand and their shared decision is made on all of the available information, which can be quite exhaustive and long. How are we going about making sure patients are truly informed before they hook up their wagon to a particular set of horses?
Yeah, that's a great notion, and so the thing that I usually do is actually the main decisions that patients face, right, are you going to do genetic testing for you and your family? Are you going to get a defibrillator? And if you're having symptoms, do you need to advance to invasive therapy? And then the last one, I know you want to talk about sports at some point. That's another one.
Yeah.
When I'm doing this conversation with patients, I try to say, we're not going to make the decision today. This is not a car deal. My manager's not in the back room. This is a special offer. You're going to think about this. You're going to go home and talk to your family and friends about it. And then we can get back on a video visit or a call or something like that as you make your decision to go forward. So it's not, you don't have to come to your one visit and expect all decisions to have to be made during that time period for just the reasons you said, Lisa.
We are also hoping, although I kind of hope this was going to be in the guidelines, but we didn't time it this way. The support groups are there as well for you to talk it out with your peers. What did you experience? What did you do? How did it work for you? Not everybody's going to have sunshine and rosy stories. Some of them are going to have some challenges. And these are things that people need to consider when they're going forward in their decision making. Now the tough one, and then we're going to go back to agenda.
Yeah.
For whatever the reason, and we kind of know that, HCM is known as the leading cause of sudden death in young athletes, and some will debate whether that's the actual truth or not, depending upon what country you live in, fine. But how do we make decisions for what level of competitive athletics? I don't want to talk about exercise. We're not talking about having a healthy lifestyle and walking on a treadmill or using an elliptical and mild exercise. We know that generally that's good. Talking about competitive, I want to do a triathlon, I want to go run a marathon, I want to be on a professional sports team, I want to be on a varsity level sports team. That decision as an adult, and by that I mean over 18, so we consider colleges in those decisions, and then children and sports versus adult and professional sports. These are all subspecialty, like sub areas of sports, but how do you make shared decision making on that?
Yeah, it is a very tricky one, and you could see that in the guidelines. We actually recommended this is one of the discussions that really should go to the highest level centers to talk about, because I mean it took us a long time to come up with the very wordy recommendation we did around this. And so the concept that we had was So let me back up. So I think that Lisa said one of the facts we know, and that is if you look at historic data about people who have died playing sports, HCM is overrepresented in that group. More recently, looking at living patients with HCM who are participating in sports have not seen unexpected or excess deaths or adverse events in those. So those two things exist, and they aren't actually mutually exclusive. It just means that the risk is high, but it's probably small enough that the studies we have can't detect that difference. So just like, there's no patient who has zero risk for sudden cardiac death. If you are an elite athlete and this is what you want to do, I'm going to have to tell you there are data that say that HCM patients represent a lion's share of the patients who have died with HCM, but with sudden cardiac death, but I can't quantify that risk for you. What we didn't feel was the right thing to do was to take the patient's physician and put that person in a position to dogmatically say, you therefore cannot do that. That's dogma that takes out patient life circumstances that might do that. I have to have the patient understand that there is risk there. The sports teams, the universities will also have their own medical and legal staff that are going to be advocating on behalf of that university. Yes, they're going to care about the patient, but my job is to care about the patient more because I'm not tied to one of those universities. And so I will talk to the person about the risks. And again, we've all seen those patients who, for their life circumstances, their opportunity to go to the next level was going to be a multi-generational, life-changing opportunity for them. And for me to just say, no, you can't play is really not being a physician. So
there is another piece of that puzzle, and that is there is a third party involved in that decision. You have the patient, you have the doctor, and you potentially have a sports team, a league, a school, an institution. Yeah, they get to say something too, don't they?
They do. So the difference is, if I do my job in discussing the risk with the patient and they decide it's important to me to do this, I want to do it, they can choose to pursue that. That won't make that team say, we're willing to take that risk. So you can't decide you're going to play for this team at this university. Maybe that team will do it, but you might have to say, well, I'm also willing to play at the University of X. Because they said, if you've had that discussion, we understand it. We talk to our sports doctors, et cetera. So there are two different decisions made there: the patient on whether they want to continue to pursue it after hearing about the potential risk, and the teams about who they want to field. And so I think that they shouldn't be mutually exclusive conversations, but I think there's different roles and responsibilities in those two discussions.
I think we need to be clear that there are more parties involved than just the patient's choice.
Exactly.
And then there's the patient, if they're, a teenager, there's the parents' wishes,
Yep.
the teenager's wishes, the doctor's wishes, the school system's wishes.
Yep.
There's a lot of variables here. I do suspect that this is going to take a little bit of pain to get through, to get to some good answers. And I don't think that this is going to necessarily resolve anybody's decision making very easily. It's going to be really difficult to make these decisions for some cases. So I just encourage that shared decision making and that communication on all parts.
Yeah, it's always going to be a long conversation and a hand-wringing conversation for sure.
Yeah, absolutely. Well, we're going to get to the rest of the questions on that later so we can keep on task for tonight. So who do we have up next? We are going to pivot to Brian Newman. We're going to talk about myectomy and different approaches here. The reason I brought up Brian, I'm going to pause here for a second. There's just been some data on recalls of Boston Scientific, one of our sponsors, devices. And I'm a little curious on one particular issue. They've had some lead fracture issues. And I'm wondering if you can speak at some point during your talk about what lead extraction would be like if somebody was doing a myectomy, because the lead seems to be having a problem at the turning point. And have you guys seen anything with SICD leads and myectomies yet, or are we too early in that? So there was my bizarre question for you.
All right, I'll do my best tackling that. All right, can you?
We see ya.
All right. So thank you for inviting me. Excellent discussion so far. So tonight I'm going to be talking about transaortic and transapical approaches to surgical myectomy. And the objectives for this talk are to briefly review traditional septal reduction therapy and outcomes, to summarize the most common anatomic variations in hypertrophic cardiomyopathy, and to highlight patient characteristics conducive to transaortic myectomy, transapical myectomy, or both. For most patients and at most HOCM centers around the country, the choice of septal reduction therapy primarily involves transaortic myectomy versus alcohol septal ablation. And although this talk will primarily emphasize transapical and transaortic approaches, it's necessary to briefly review these treatment options as an introduction to the topic. So for transaortic surgical myectomy, as the name implies, an incision or aortotomy is performed at the proximal ascending aorta. This gives the surgeon visualization and exposure of the aortic valve cusps, which are carefully retracted to prevent injury, and exposure of the proximal basal septum, which is carefully excised, and a trough is cut into the muscle to allow increased flow of blood. In contrast, with alcohol septal ablation, a catheter is advanced carefully up the ascending aorta, up the transthoracic aorta, into the proximal left coronary artery, and then into what's called the first septal perforator. And these are referred as septal perforators because they penetrate or perforate the myocardium. And then about 1 cc of alcohol is injected to cause a localized infarction. And the major outcomes between the two procedures are similar, specifically with respect to mortality and 30-day major adverse outcomes. And these are the aspirational targets. In real-world practice, however, there are important differences. Specifically, with alcohol septal ablation, there's a higher rate of need for reintervention for residual obstruction, and there's a higher rate of pacemaker implantation. And this is a single center review with real-world data. And patient selection is critical for choosing the appropriate septal reduction therapy. And this is a patient, obviously, who would not be appropriate for alcohol septal ablation. This patient has severe diffuse septal hypertrophy, whereas alcohol septal ablation causes a very focal and localized infarct. And there are certain anatomic features that are necessary for successful alcohol septal ablation. And this requires a prominent septal perforator that supplies the myocardium at the site of obstruction. And this is a cardiac MRI from a patient with basal septal hypertrophy, dynamic outflow tract obstruction, pre-procedure. And the arrow points to the localized area of obstruction. But unfortunately, this patient, after alcohol septal ablation, still had residual obstruction. And you can see the site of ablation was just distal to the obstruction. Fortunately, this patient was able to then undergo surgical myectomy and had a very good outcome. So there are several common scenarios where residual obstruction is more common with surgical myectomy. And these are patients who have inadequate septal resection. And this is most often patients with complex septal anatomy, or what's referred to as long segment hypertrophy, and I'll review that, as well as patients with midventricular obstruction. And it's important to be aware of the different septal morphology patterns so that you can choose the appropriate therapy for the patient. Sigmoid septal hypertrophy is the most common, and sigmoid refers to the sigmoid flow of blood as it's ejected from the left ventricle. And in these patients, hypertrophy is most prominent at the proximal basal septum. Next most common is reverse curve morphology. And these are patients whose hypertrophy is most prominent at the distal third. In contrast, patients with apical variant hypertrophic cardiomyopathy, as the name implies, hypertrophy is most prominent at the apex. And these patients are characterized by a small left ventricular chamber. And lastly, and least common, are patients with neutral septal morphology. These are the patients whose hypertrophy is most prominent at the mid-third of the ventricular septum. This is a patient with midventricular obstruction. You can see the echo image on the right with color aliasing, and I've highlighted there, and that's at the level of the papillary muscle. And I've highlighted that on the schematic on the left, the illustration. This is an MRI image on the left and an echo image on the right in a patient with apical variant hypertrophic cardiomyopathy. Again, the arrows indicate hypertrophy most prominent at the apex. You see a very small left ventricular cavity, which is often accompanied by a small left ventricular stroke volume and symptoms of heart failure. Both apical variant hypertrophic cardiomyopathy and midventricular obstruction are difficult entities to diagnose and treat. Unfortunately, they often respond poorly to medical therapy. And treatment options for these patients, specifically the apical variant form, are limited to myectomy or cardiac transplantation. Apical variant hypertrophic cardiomyopathy, as I mentioned, is characterized by a small left ventricular cavity, and the thick heart muscle walls give rise to a stiff heart chamber. And I think this is it helps patients to visualize. I kind of have them think of one of these thick rubber hot water pads versus a thin party balloon. You can imagine if you tried to blow up one of these thick hot water pads, how difficult and the amount of pressure it would take to distend the cavity. Whereas a party balloon with a very thin walls is easily distended under much less pressure. That's what these patients often experience. Very high pressures inside the heart, and particularly with exercise, as the pressures rise, this pressure is transmitted back to the lungs, and these patients feel the chest pressure, the shortness of breath related to the physiology. There are certain scenarios where transapical myectomy can be performed with success. And this is in patients with complex septal hypertrophy, particularly the reverse curve and neutral variants. The patients with apical hypertrophy with a small and stiff left ventricular chamber, and those with an apical left ventricular aneurysm. For patients with the apical variant, the transapical myectomy allows enlargement of the left ventricular cavity. An incision is made at the LV apex. The apical muscle is resected, and you can see on the right, these are MRI images pre and post-op. You can see substantial enlargement of the left ventricular cavity at the apex. This increases the left ventricular stroke volume, the cardiac output, and helps relieve the symptoms of heart failure. This was a small study from our center, but 44 patients with apical variant hypertrophic cardiomyopathy, severely symptomatic. 96% of patients had NYHA class 3 or 4 heart failure, and there was a high burden of syncope and angina in these patients. And at 3 years of follow-up, there was sustained durable benefit, with 74% of patients reporting NYHA class 1 or 2 symptoms. And these are some intraoperative photographs of a patient. In panel A, you can see the left ventricular apex is exposed, an incision is made, and here you can see the tan myocardium, very thick hypertrophied muscle at the apex. It's crowding the left ventricular apex. In panel C, after resection and debulking, you can see the left ventricular cavity is significantly enlarged. And then in panel D, the transapical incision is closed with felt strips and sutures. Some patients also require a combined approach, both a transaortic and a transapical approach. And this is particularly more common in patients who have very long segment septal hypertrophy, as in this image. I've shown the cardiac MRI on the left. And in retrospective review from our center, at 30 months, just over 97% of patients reported durable relief of symptoms. Again, class 1 or class 2 heart failure symptoms at follow-up. Left ventricular apical aneurysms are a very unique manifestation in hypertrophic cardiomyopathy, most prominent in patients with the apical variant form. This is a transthoracic echo image on the right. For small aneurysms, multimodality imaging is critical. Small aneurysms can frequently be missed with transthoracic echo, even with contrast enhancement. Cardiac MRI is very helpful in these patients. And in the past, we used to use a lot more left ventriculograms to identify. This is a patient on the right. You can see the left ventriculogram with contrast pooling at the apical aneurysm. This is an autopsy photograph of a patient with a left ventricular aneurysm, the very thin-walled myocardium. I think the best analogy for this is a tire bubble. For tires, it's often due to a manufacturer defect where the rubber thins, the high pressure inside the tire over time causes this bubble to slowly expand into an aneurysm. For patients, we can't blame a manufacturer defect, but it's most often due to ischemia at the left ventricular apex, that over time, the high pressure inside the ventricular cavity causes progressive thinning, and thin walls often are prone to aneurysmal formation. So the procedure for patients with a left ventricular apical aneurysm, again, involves an incision at the LV apex. Any muscle that contributes to midventricular obstruction is resected, which results in cavity enlargement. And then the apical incision site is closed in the way that I mentioned previously with felt strips and sutures. And these are cardiac MRI pre and post images of a patient who underwent apical aneurysm resection and debulking. And you can see in the post-op images, there's a significant improvement in global left ventricular function. And this patient did very well at follow-up. So in summary, I think it's important to be aware that regardless of the septal morphology pattern, we have treatment options to help patients achieve improved functional capacity and achieve their goals of care and an improved quality of life. So in summary, alcohol septal ablation and surgical myectomy result in similar survival, but alcohol septal ablation is associated with increased heart block and need for pacemaker placement, as well as a higher rate of redo procedure for residual obstruction. The septal morphology and site of obstruction is critical because it influences the choice of septal reduction therapy. And this is why we push so strongly for multimodality imaging in these patients. In transaortic myectomy, transapical myectomy, or combined approaches are treatment options for patients with complex septal hypertrophy. And with that, I'll open it up to questions.
I'm going to swing back, and I know it's not completely related, but have you guys had any experience yet with SICD and myectomy and lead placement? Or has that not happened yet?
Are you talking about the lead fracture that you were referring to earlier?
So they brought up a couple of things. I've had a couple of people debating devices. Some of them are possibly on a myectomy pathway with gradients in the 40s, 50s, and slightly going up. And what is the interplay between the lead placement and doing surgery? And then also there's the lead fracture issue. Have you seen anything with that yet?
So we did. It seemed like we had a lot of lead fractures. I shouldn't say a lot, but the frequency really seemed to increase 3 to 5 years ago is when I remember this on the radar. For us, our heart rhythm colleagues are often involved in device extraction. I don't think I had any patients who went on to surgical myectomy that then required intraoperative extraction. I don't know, Geske or Steve, if y'all can comment on that. It really hasn't come up frequently in my practice, to be honest.
I have not seen any of my patients have that issue, Lisa. So
no, I have come across patients who have had a subcutaneous defibrillator placed and then gone on to need of myectomy. And one of the concerns there, because a subcutaneous defibrillator has this tunneled lead that runs right alongside the sternum, the sternal incision can be quite close to where the lead runs. I've had 2 patients in recent past with this scenario. One, the lead was tunneled sufficiently far away from the midline that it really was not an issue at all. The sternotomy was performed. It was never even close to where the lead was. There was no issue with lead function. The healing occurred fine. There was no infection. Another patient, just on examining them, the lead was quite close to the sternum. And in that patient, I discussed with our surgeon. We did additional imaging to define the location of the lead, and the surgeon was very careful when making the sternotomy to plan the operative incision with that in mind, and had discussed with the patient the fact that because of the proximity to the incision, there was possibility of need for lead or device revision.
Okay.
We have had 2 of those recently also, and did additional advanced imaging just in pre-op surgical planning. Both did fine.
Yeah, it's one of those things that I don't think we really thought of up front when we're thinking about SICDs and then the possible need for myectomy later. So just something that patients might want to think about if they are already showing obstructive physiology. Getting back into the apical versus traditional approach of myectomy. Have you guys done a real side-to-side comparison on quality of life after the 2 various types of myectomies?
No, I haven't seen any side-by-side comparisons, but the outcomes in the small follow-up studies of the patients who have undergone this approach, their outcomes are quite similar to patients who undergo traditional transaortic myectomy. The problem is we're talking about small groups of patients when we're talking about transapical approaches. These are also newer techniques, and I realize the references that I had at the bottom of the slide were a little bit smaller, but we're talking about 2018 and 2019 studies. Hence, we don't have long-term follow-up like we do in the transaortic approach. But so far, the outcomes seem to be really good in the short term, and it's important to remember these are patients who really didn't have alternative options.
Right.
Absolutely. Okay, we're going to pivot. We have some questions that we'll take at the end so I can kind of get them organized. Our faculty is welcome to answer the Q&As at the bottom, and I will go over those Q&As that you guys answered one-on-one. I'll put those out there for the entire community later because of course we have some COVID questions and some other stuff too. Okay, so we're going to hand it over to Jeff Geske, who is going to talk to us about what's going on in research. Very cool stuff going on in research today. We've picked a good time to be interested in hypertrophic cardiomyopathy. Jeff, off to you.
All right. I'm going to share my screen there and get started. Hopefully that's coming through okay.
That's beautiful. You're good.
So my topic is going to be HCM research, and specifically looking at some of the endeavors that are going on at Mayo Clinic and what's new. And every time I look at research, I'm always struck by when we answer one question, it seems that 3 or 4 can open up in after that's occurred. So I think I wouldn't be surprised if in looking at some of these results, if you've not heard of them, that additional questions come up. I've included a lot of things that are very recent, and so it may be that we don't have those answers, but we certainly value the questions and insights that come about from patients and other providers as they look over new research. I'm going to be talking a bit about Mavacampton, and it's fair to know that I have a consulting relationship with MyoKardia, who was recently acquired by Bristol Myers Squibb, and I'm our principal investigator for the VALOR HCM trial at Mayo Clinic, and we'll be talking about that. So today, I really want to go through some recently published Mayo Clinic research in HCM, as well as tell you about some exciting things that we're doing that's ongoing as far as research in HCM at Mayo Clinic. And you might say, well, why do I care about what's going on at Mayo Clinic? Why don't you just cover all of HCM research? And it's because Mayo has a really unique status. If you look here, these are patients who have been referred to Mayo just between 2002 and 2019. And you can see that although sites, we have these 3 primary sites, with the largest being there in Minnesota at the giant red blob, we're seeing patients with HCM from across the country and across the world. And I know, Jane, you showed some numbers back from about a decade ago, but in even recent years, we're seeing even larger numbers of patients that are referred to HCM, and likely because of the recognition, as Steve has shown, that there are better outcomes associated with patients seen at these large referral centers of excellence. So for this talk, I'd like to show you an outline. We'll first start talking about some genetics and molecular biology that's been studied. We'll then move on to ECG screening and have some discussions about how machine learning is actually guiding our knowledge of ECG screening. We're then going to talk about some sex differences, ways where HCM occurs differently and behaves differently between men and women. We'll talk about some septal reduction therapies with a focus more on myectomy. We'll talk about ways that we're detecting arrhythmias and how we're understanding sudden cardiac death risk as we move into more advanced understanding of those risk factors with the recent guidelines and more advanced ways to do screening. And then we'll finish off with some therapeutic discussions, largely focused around Mavacampton, which is kind of the new kid on the block. So let's first start off talking about genetics and molecular biology. And genetic screening is a really important part of understanding the diagnosis of HCM, as well as understanding how it affects family members. But when we look at patients, not everyone do we find the gene. And it's interesting that when we see a patient, we can figure out what the likelihood of them having genetic positivity is by looking at certain aspects of their clinical demographics, as well as their imaging. And we've identified 6 major things that we can look at. If a patient is age under 45, if their maximal wall thickness is greater than 20 millimeters, if they have a known family history of HCM, if they have a known family history of sudden cardiac death, if, as Brian showed us, the shape of their hypertrophy, that morphology, has a reverse curve, and if they do not have a history of hypertension, we can then use those in a model to predict what the likelihood is that when a patient with HCM undergoes genetic testing, that we're likely to find the causative mutation. And I think this is important as we see patients and families to set expectations and to help with decision-making as to whether or not this is the right approach for your diagnosis and for your family care. When we look at molecular biology, something that's certainly been a big question on many patients' minds is, how does my hypertrophic cardiomyopathy affect my risk should I obtain COVID? Now, our labs have looked at something called ACE2. And ACE2 is a cellular receptor that coronavirus uses to enter into the cell. And when we look at patients with hypertrophic cardiomyopathy, we see that ACE2 is upregulated. And not only is it upregulated a little bit, it's upregulated 5-fold in patients with hypertrophic cardiomyopathy. And you might say, well, why is that? What is ACE2? I haven't heard of that. ACE2 is a gene that helps to try and promote anti-hypertrophy and anti-fibrotic response. And so in patients with thick hearts, in patients who have scars in their hearts, this can be upregulated as the body's way to try and combat those changes. Now, when we see this, it makes us wonder if with that upregulation of ACE2, are these patients then at increased susceptibility, or could they have a more severe disease response should they have an infection that utilizes that receptor for entry into the cell? And I think this translates to some of the things that we've seen where patients with HCM are listed in higher risk groups in some discussions regarding coronavirus infection. So that's just a few brief things about genetics and molecular biology. And I realize that we could spend a whole talk on each one of these things, but I really want to give a potpourri or a sampling of different things with this talk. Let's next talk about ECG screening as well as some machine learning that's going on in Mayo Clinic research. Artificial intelligence has been a really burgeoning part of research in the medical field. And we took a large ECG repository that we have at Mayo Clinic, looking at 3,000 patients with HCM and nearly 64,000 patients without HCM, and had a computer look at the electrocardiograms and try to figure out if that computer can determine whether a patient has HCM just by looking at their ECG. So this is a complex model, and this just kind of shows that initially a large group was used to train, and then there was some validation that occurred, and then that model was tested in over 13,000 patients. And what we learned is that this computer artificial intelligence is actually quite good at identifying hypertrophic cardiomyopathy solely on the basis of an ECG. And one thing that I found particularly exciting is that it performed quite well in young patients. Those under age 40 had some of the best performance of the model. And the model was very good at a negative predictive value, meaning if the ECG fed into this artificial intelligence machine learning, if it says this is unlikely to have HCM, then it was quite unlikely that the patient actually ended up having HCM. I think this is really exciting, and you can imagine how this could potentially play into screening discussions. And so we're now taking next steps. You see, this was just published in 2020. This is bleeding edge research. And what is Mayo doing next with this? Well, we're looking at it internationally in patients from UK, Italy, Switzerland, South Korea. Does this perform well in an international model? Is it validated outside of the Mayo system? We're looking at it in professional athletes because they may have different ECGs. Many times athletes can have thickening of their heart that's not from HCM, but from their athlete changes. We can look at this in children and adolescents and see how it performs there. We can see, do wearable ECGs, things like Apple Watch, or in particular the Alive Core device, are we able to use that sort of ECG data to help us identify HCM? And if we have patients who have maybe obtained an ECG for another reason, we don't know they have HCM, we're now starting a study where we look at those cases and we go and do imaging to find out if the ECG model found that it was likely that they have HCM. Are we missing things that we could potentially find because of just an ECG performed? Now, when we look at large data, some of these numbers that we're talking about, tens of thousands of patients, we can really grow this data quickly, right? You just think about demographics, ECG findings, medications, echocardiographic findings, symptoms, and the data balloons very quickly. And what we're finding is that artificial intelligence, machine learning, natural language processing, these advanced techniques that are developing where computers can help us process that data are going to help us derive care models where we can use that information real time to say, hey, listen, that test was just done. Here's an alert to the provider that helps provide the right treatment to the right patient during their clinical course and keeps them up to date with what the experts perhaps know or the latest guidelines to make sure this is integrated into healthcare systems. Well, what do we know about differences between men and women with hypertrophic cardiomyopathy? This is something that's really been studied more recently in the last few years. And at Mayo, we looked at a large cohort of patients with hypertrophic cardiomyopathy, so over 3,500 patients with HCM. And we said, how do men and women differ? So compared to men, women have more obstruction, more mitral regurgitation, worse diastolic function, more pulmonary hypertension, more symptoms, worse exercise performance. But despite having this worse clinical phenotype, are older at the time that they're referred to a tertiary center like Mayo Clinic. And I think the biggest kicker, the thing that struck me most, is that when women are compared to men, women have worse survival. So here's a study looking at women in red and men in blue. This is that same cohort of 3,600 male patients. And we can see that women have worse survival when compared to men. And when we took this large study and we considered a lot of different factors, even in a multivariable analysis where we considered other things, other differences between these populations, sex still mattered. Which in my mind begs the question, should we be treating women more aggressively? With this sort of data, do we need to individualize care and treat women more aggressively? A next logical question then is, how do women do after myectomy? And if we look at that, when we consider those important prognostic factors, when we adjust for those, following myectomy, there was not a survival difference when we looked at Mayo Clinic. Survival was similar between men and women post-myectomy. And to me, this then says early identification and prompt treatment and consideration of care in women in particular is quite important. That perhaps men and women need different assessments in hypertrophic cardiomyopathy and individualized care plans. It goes back to some of that shared decision-making that Steve really highlighted nicely. I think that's a nice transition to talk a little bit about septal reduction therapy. And so let's transition into that next. If we go beyond the Mayo bubble and we transition out and we look at the national inpatient data, so this is looking at all hospitals across the US, we can see a larger number of HCM admissions, a good amount of which were for myectomy. And when we look at these HCM admissions, we can see that there's disparities, that utilization of therapies and outcomes are different depending on what you look like in the mirror. What do I mean by that? Racial minorities and patients with lowest incomes are less likely to receive myectomy. I think that's pretty powerful. And if we look at this large inpatient sample across the United States and we say, how do patients do? Women, those who are not white, and those who undergo a concomitant operation, something like a bypass or a valve surgery, have higher in-hospital mortality. Again, you may recall that women didn't have different outcomes looking at the Mayo data. And perhaps, again, this speaks to the importance of having centers that are familiar with this. And we need to make sure that we're really individualizing care here and aware of some of these disparities. This is a bit of a busy slide, and for that, I apologize. when we think about risk and some of these predictions, right? We were talking about prediction of sudden cardiac death risk, but when you're predicting the outcome of a surgery and the risk of death or bad things happening, there's not a risk predictor that's around for myectomy. But there are some standardized risk predictors that are available for somewhat similar procedures. And what do I mean by that? They're in the same anatomic neighborhood and often are performed via a sternotomy with similar approach, those being mitral valve repair and aortic valve replacement. So we said, if we take a group of patients that underwent myectomy and we know their outcomes, and we then pretended that they didn't have HOCM, but instead they had mitral valve needing repair, or they had an aortic valve that needed replacement, and we plugged them into those calculators, how do those calculators approximate risk for patients with hypertrophic cardiomyopathy? And what we found out is that at Mayo, when we look at our outcomes with myectomy, we beat the curve. So even with those similar sort of procedures, and perhaps even a more complex procedure, that being myectomy, it's so experience and procedure dependent, that we could see that at Mayo Clinic, myectomy risk tended to be lower than those standardized risk calculators would suggest for mitral valve repair and aortic valve replacement. And Brian's done a really nice job of talking about transapical myectomy. And we've seen from our research that this approach, where we go in through the apex and are able to relieve obstruction or cavity obliteration that occurs deeper than we could reach when we do a standard transaortic incision, really is a safe approach. And sometimes it takes both approaches, from going both transaortic as well as transapical. I'd like to next talk a little bit about risk stratification and some of the different screening things that we're studying now. And this device, to me, it looks kind of like a flash drive, you know, like a thumbstick or a USB drive. It's actually a little bit smaller than that, but this is an implantable loop recorder. And this is a small device that can be implanted underneath the skin. Why would we do something like that? It's because when we look at the decision tree that Steve has nicely put together in the US guidelines, and we look at some of the factors that go into deciding if an ICD is needed, one of the key decisions is looking at non-sustained ventricular tachycardia. Well, currently, when we look at that, we might get an ECG or have someone on the treadmill for 10 minutes or do a Holter monitor for a day. But how do we know that that brief sampling of data catches what we want to know? I don't know. That's a good question. How should we assess the burden of arrhythmia in patients with HCM? And we think this is an interesting way to do it, to prospectively give patients a small device that's always with them that can assess for symptomatic or asymptomatic arrhythmias. And we've partnered, Medtronic has given us some of these devices that we're able to offer to patients with hypertrophic cardiomyopathy. And the inclusion criteria for this study is that a patient has HCM, that they do not have a pacemaker or a defibrillator in place, and that they don't have any known arrhythmias, that we don't know about atrial fibrillation or ventricular tachycardia already. And for patients that meet those three criteria, we're able to offer them this device to have a small implant that monitors them to help with further decision making. We've put this in greater than 20 patients, and we have a line of patients that are waiting to be implanted. Some of the timing of implants have been shifted around given COVID. And not to spoil the end results, but I can tell you that several of my patients who have participated in this trial, we have found arrhythmias that we would not have known about if it weren't for this device. Another interesting part of the guidelines, and one thing that's changed a bit, is the emphasis on apical aneurysm. And Brian showed some nice pictures of that. And Steve has talked about how the weight of certain things has been adjusted based on evidence. And we are doing some research at Mayo to understand the natural history. How do these evolve? How do they change over time? What do patients with apical aneurysms or apical pouches shown here on this cardiac MRI, how do these change or evolve over time? And what can we understand when we look at the Mayo cohort of patients that have this finding? Here's an example of a pouch shown on MRI, and this pouch actually had a small thrombus, which would be a risk for stroke in that patient. Lastly, I'd like to talk about some novel therapeutics, with the focus being on Mavacampton. And Mavacampton is kind of the new kid on the block. It's a drug that's undergoing phase 3 clinical trials. It's a modulator of cardiac myosin, which is not the same as a beta blocker. This is a new drug class. And when I think of how this works, if we dive down into the sarcomere of the myocytes, there's too many cross bridges. There are too many linkages between myosin and actin inside of the heart of patients with hypertrophic cardiomyopathy. And these cross bridges cause the heart to be hypercontractile and may contribute to tissue disorder. What Mavacampton does is it reduces cross bridging. And in doing so, it lowers contractility, it normalizes that. It may assist in relaxation, which I think is an interesting area of study that could be looked at in non-obstructive patients. And it may organize the sarcomeres given this lack of cross-bridging. So the studies that have been done, there's been the Pioneer HCM. This was an earlier trial, a phase 2 trial, which means it was a smaller trial looking at patients with obstructive HCM. And we saw that it reduces LVOT gradient, that it improves exercise performance, that in these hyperdynamic patients, that the ejection fraction decreased and that symptoms improved. And in a larger study, a phase 3 trial with a placebo control, we could see that in patients who are majority class 2, meaning have symptoms, but generally not as severe of symptoms, about 3/4 of the patients were class 2, when we continued their baseline medicines, that we saw similar results of reduction in LVOT gradient, improvement in exercise performance, and improvement of symptoms that was fairly well tolerated. Well, if that's the case in class 2, what about more symptomatic patients, class 3 or 4 patients who are trying to make that decision as to whether or not to proceed to septal reduction, be it myectomy or alcohol septal ablation? In those patients, does Mavacampton reduce the need for septal reduction therapy? How does it improve symptoms in those more symptomatic patients? And what degree of LVOT obstruction improvement do we see in them? And that's really what this VALOR HCM trial is looking at. And Mayo Clinic has just begun, we've just initiated, we got the green light for this within the past week, and we'll be enrolling for this trial. So these patients that would enter this trial would be HCM patients who are considering septal reduction therapy. So it's been recommended to consider myectomy or alcohol ablation. You're on maximally tolerated therapy. You are symptomatic in class 3 or class 4, which has prompted this septal reduction therapy to be recommended. And you have severe obstruction, a gradient of 50 millimeters of mercury at rest or with Valsalva. And in those patients, you could enter into this trial that is initially placebo controlled. So some patients will receive placebo, some will receive Mavacampton, but after a period of time, a period of several weeks, all placebo patients will eventually cross over and be available to receive Mavacampton. There's frequent follow-up because the drug is being studied in highly symptomatic patients, and it's a drug that's not yet FDA approved, although we can tell from available safety data that it seems to be well tolerated. So there is frequent follow-up, and some of that requires face-to-face evaluation, while others may be possible through health telemedicine visits or through even echocardiograms that may be able to be performed in the patient's home. Patients involved in the trial have the option to continue on Mavacampton up until that's available commercially. And background therapies, beta blockers, the medicines that you're already on are continued throughout the trial. So that's a lot of information about this trial. It's something that's just opening up at Mayo Clinic, but I think it is a really unique trial that I wanted to make sure I discussed. been through a lot already in this talk, and I'm excited to look at the questions that come up. We've talked about genetics and biochemical molecular biology. We've talked about ECG screening and artificial intelligence, sex differences in HCM, septal reduction therapy, arrhythmia detection and monitoring and its role in sudden cardiac death risk decision-making, as well as novel therapeutics in HCM. And for that, I would like to thank you for your time. With that, I'm going to transition just very briefly before we go into answering some questions, and I look forward to those and discussing with folks. If you wanted to be evaluated at Mayo Clinic, say you heard something from Dr. Rahman about shared decision making, you are interested in some of the myectomy techniques that Dr. Newman discussed, you heard about a research trial that I've discussed that might pertain to you, or even if none of those are the case and you just want to have an opinion at Mayo Clinic, how would you go about being seen by our HCM clinic providers? Well, you can see there's a lot of smiling faces there. We'd be happy to see you. We really are passionate about this. We think that this is very important. We think that the individualized care and the time to discuss your unique care with you is really important because the needs of the patient come first, and we thoroughly believe that. And so if you wanted to get a visit with one of these providers, it's as easy as a phone call away. And I put here front and center Rhonda, who is just absolutely fantastic. She is a key cog in the gear of setting things up. And she's available. This large red phone number that's on your screen would be a great way that you could contact. Patients can call and set this up. Providers can call and set this up. If you're thinking that you want more, that you don't want just the HCM quarterback, but you have other aspects of your care, then it might be worthwhile to contact this more general line. But if you're really looking primarily to be seen in the HCM center, then Rhonda would be happy to talk with you at this number, and we'd be happy to see you. So with that, I will turn it back to Lisa for questions or to go into the breakout, or however, Lisa, you think it's best to proceed.
So what we're going to do next is we're going to bring everybody back up onto our little Brady Bunch screen here. And I'm going to go through some of the written questions, and we're going to continue to stream on Facebook for a few more minutes. And then we will take Facebook down, and we will take recording down, and we will answer questions by hand raise from the panelists. So boy, do I have a lot of questions for you guys. Okay, so I'm going to kind of go potpourri order, so we'll just kind of bounce around here a little bit. Some of the questions were answered already on a one-on-one basis. If I think they really are applicable to the group, I will read them out. Please don't use the chat feature, use the question feature. It helps me keep things organized. So we'd appreciate that. So Barbara's question, what are the steps for myectomy in terms of when does the surgeon know they will do, and when are the tests done before getting a myectomy? For example, does your HCM, I think you mean gatekeeper, so the director or the physician, coordinate with the surgeon, or do you go straight to the surgeon? Just knock on Hartzell's door and say, I'm in, or is there a little bit more to it? Who wants to comment on the process of getting to myectomy?
I can jump in. I'm happy to. I laughed a little bit when I saw the question because it's almost rhetorical. When does the surgeon not know what to do, right?
Exactly.
Some surgeons may not admit to it, but it's definitely collaborative. It takes a lot of communication. Most patients with hypertrophic cardiomyopathy, and I'm hesitant to say this a little bit, most of the patients we see are fairly straightforward because they have dynamic obstruction at the proximal basal septum, and that's where the septalectomy was pioneered for that location. But in terms of the more complicated patients, it can start in the echo lab. Well, maybe Dr. Geske will be reading echoes that day, and he'll give me a call and he'll say, hey, this was a complex echo. I just wanted to give you a heads up. This is what I saw. I bring up the images in clinic with the patient. We review their MRI, their echo side. If you recall the echo image that I showed, the midventricular obstruction with the color alacing the midventricle, all those clues help decide what's the optimal approach for the patient. And then if it's a complicated patient, certainly we give Hartzell a call, Joe Durrani a call, Hartzell Chef, or Joe Durrani a call and say, hey, look, just wanted to give you a heads up. I think this one would be amenable to both a transaortic and a transapical approach, something along that nature. sure. But it really, it's a collaborative approach for the patients that, you know, straightforward and highly complicated. It's just a lot of communication. And I don't know, Steve or Jeff, anything to add there?
No, I think you covered that. It really is. I mean, again, we get the benefit of, again, many of the patients have been diagnosed, have great imaging, and we can see up front. And so we can be pretty certain about what the surgical plan is going to be even before they make their travel plans to come see us. So, but during, I mean, I get into the nitty gritty of during the operative procedure, the surgeons go through a few things during the procedure. They will do the myectomy, and then there's a few things they do to make sure they've done enough of a myectomy before they let the patient leave the operating room. So they will, you know, put everything, do the myectomy, and then test the heart again. And if there's still obstruction, they'll go back in and do some more. So it is a standard kind of, you hear about surgical checklists. Well, that's part of the surgical checklist for myectomy, is to make sure the job was done.
The decision process is really collaborative, and that's why Center of Excellence care matters. I don't think you just, yes, sometimes people go directly to the surgeon from an outside physician as a referral, but typically they're seen at the HCM center, and then they're evaluated by the team, and the approach that is best for that patient is discussed among the team, presented to the patient. Patient gets to be involved in that decision making, and then they go off to surgery. And typically,
in fact, Lisa, you know, as many of our patients do get referred directly to our two surgeons, but they always send the patient to us as well, because surgeons aren't going to address the questions about ICDs, activity levels, genetic testing, those kind of things. So they, you know, as you said, it is a complete, no matter which door you walk into, you're going to end up with the HCM team.
Yeah. And one really unique aspect about Mayo Clinic that we haven't mentioned is during every single myectomy that occurs at Mayo Clinic, there's a cardiologist in that OR who's doing part of that monitoring that Steve mentioned. There's ultrasound monitoring that's done of the heart both before and after the surgery that helps to guide the surgery, discuss the care plan during the operation, and check the immediate result before the patient ever leaves the OR.
and most of our high volume surgical programs use that model. And where did that model come from? Pretty much Mayo and Cleveland's experience on how they were doing it. So you can go to the original or an imitator, right? So once somebody has a myectomy and they come in as a hokum, how do they leave? Are they cured?
So they're not cured. No, it's a great question. So they still, I mean, the muscle that's there, that's still left inside the patient, still has hypertrophic cardiomyopathy at the cellular level. So some of the things with stiffness of the heart and those kind of things are still there. They don't have outflow tract obstruction anymore, which means they can use some other medications, maybe for, if they have hypertension, well, that opens up a whole bunch of medications that now can be used that were maybe not successful when they still had obstruction, but they kind of transition over to the non-obstructive arm of things.
So I have a trick question for the crowd. So what are your thoughts on the future of myectomy? Can we do lasers, robotic, minimally invasive? We figured out a way to cut more by going through the apex and clearing that out. That's an advance in myectomy, but where are we going? Are we going anywhere?
That's a great question. I'll jump in here on this one. You know, there've been a lot of treatment options along the way that have held great promise, but didn't hold up to scrutiny. I think one of the most memorable is dual chamber pacing. But one of the treatment options that I'm really excited about, we have small experience, is radiofrequency ablation. You know, there was a recent paper that was published, and we have some proceduralists who've done some very, very limited procedures on this. But for patients who might not be candidates for alcohol septal ablation because they don't have the right septal perforator anatomy, this may be one option. But again, this is very, very early. And we're not really talking about this as a broad treatment option.
Anybody else want to chime in on additional
I would
ways?
I would just add that again, you know, the biggest indication for surgery is relief of symptoms. And so certainly as a patient, You want to think about how bothersome your symptoms are for your lifestyle. And you certainly want to pursue the treatment that has the potential to give you the best benefit, in the hopes that it's a one and done type of a treatment for you. So I think that definitely factors into your decision making.
Excellent point. I will just say that over the past 25 years, lots of people have tried to find the new way to skin the cat.
Yes.
And how we can put alcohol in there, we can put coils in there, we can try robotic, everybody wants to come up with a better way to treat obstruction. I like kind of the drug therapy approach. Let's normalize the heart entirely and maybe not be obstructed. That would be a really great thing. But I would caution, there are a few small programs out there that are selling new concepts in surgical approaches. And I offer caution to anybody who is taking that talking point and thinking, well, that sounds good, I'm going to go do that. There's a reason why Mayo Clinic is saying, we're not doing that. They have experience, they have volume, they are researching. They don't want to find ways to make things more difficult for you to get to a non-obstructed state. They would love to find an easier way too. But if it's not proven out by the science and there's problems with the procedure, please don't try to take an easy way out because somebody's telling you they know better than comprehensive multidisciplinary programs who focus decades and decades on this disease. Please go to the thought leaders on this particular topic. I've seen damage done in many ways. Please be careful. Okay. What is non-compaction?
That's the $1 million question.
You are right. You are right. What is non-compaction?
But it's not really related to it. Actually, unrelated to hypertrophic cardiomyopathy, although they share some of the same pathogenic mutations. But it's a cardiomyopathy that's identified most often on echocardiogram, characterized by a spongy, non-compacted myocardium. And I think we can leave it at that for the purpose of this conference.
Thank you. Okay, so let's go into the gender differences. And Gwen is asking a really great question here. Gender differences in heart disease are well known. Is the later referral for women contributing to lower survival rates and worse outcomes?
It is a great question. And in the study that I showed, the 3,600 patient study, we accounted for age when we studied the survival differences, and there were still sex-based differences in survival. So it's true that when you look at smaller studies, so some of the other studies, 1,000 patients, once you account for all these other variables, then sex falls out. But it may be that that just wasn't a big enough study to really understand when you're thinking about a lot of complex variables. Now, an even higher level question is, how does the interplay of age and all these social factors come together? Why are women being referred later? Is it that we don't recognize the symptoms? Is it, like you showed, Lisa, that chart of differential diagnosis or misdiagnoses? Is that what's occurring? Are there social differences in our healthcare delivery? And I don't know. It's one of these great questions where we found this, and it's across the board. We see that women are doing worse, but then we have to say, why is that? And it's such an important thing. This is half of the world. How do we change this disparity between sexes and make sure that we're treating women as we should?
I will give a personal observation here. Women are treated for advanced heart failure later because we're fine until we're not. And we don't want to admit that there's a problem because everybody else needs us more than we need ourselves. That was my world. I was fine until I literally was staring at a gray wall in a hospital going, how do I not die? And I needed a transplant because I ignored it so long, because I'm compensated for my slow progression of symptoms over 36 years. It was normal. It was normal. It was normal. We need to complain more. If a man has a cold, he's headed to ICU. If a woman,
boy.
Yeah.
My wife tells me I get the man cold all the time. I'm guilty.
Have a kid, it'll change. So I think there's pain tolerances and I think we're more accustomed to being uncomfortable in our bodies, and we just adapt. And we need to speak up over our symptoms and recognize them and put ourselves first instead of putting everybody else in our lives first. That is one part of the problem. That is not the complete problem. I have long believed that there are some hormone drivers in here. The onset of menopause leads to the deterioration of hypertrophic cardiomyopathy. It happened to me. It's happened to many other women I know who went to the transplant route. It's a place where we need to spend some time in and investigate, because it's a thing. Why? Can we do something to stop the thing? Well, I leave that to you guys. You know, that's above my pay grade. I can tell you where the problem is. Now go solve it. Okay. So that's really interesting. There was another one. How long do link monitors and implantable loop monitors, how long do they stay? 3 to 5 years, something like that?
Yep. So the study that we're doing, the device can be implanted. The study will likely end before the battery dies. And if you wanted the device removed as part of the study, that can be performed at no cost as part of the study. The patients that I've talked to have been implanted. It's a very small little device. It's barely visible. That doesn't bother them. They just say, well, leave it in as long as it's monitoring me. The more information, the better. And we see that these devices can last years as far as that battery.
Okay, so we talked a little bit about artificial intelligence and using that for EKGs, et cetera. So that's a really cool study. Obviously, I love it because it's going to help us get to diagnosis sooner, theoretically. But let's talk about real timelines. We have a study at the Mayo Clinic that says this seems to work. You've gone further. You're bringing in your colleagues to say, does this really work? I've got another group of people who are interested in looking at this from another point of view that I'm helping with on another study to kind of validate all of this. So there's all these studies going on. How long does it take to go from, that's a great idea, says the Mayo Clinic team, to the world being able to have the resources and access to make this functional in a realistic sense in the United States alone?
That's a great question, Jeff. I'll make a few comments and you can jump in. I mean,
Yeah.
Historically, the pathway from idea to clinical practice, I think, has been said is 17 years. But that's changing, and this ECG one in particular likely can have a much faster pathway than historically has happened, in part because of the era of digital healthcare, 5G networks, and those types of things. So the thing that makes those AI engines work is having the raw ECG signal, not the piece of paper, but having the raw electronic signal, which businesses will make available to any hospital system to easily upload their ECGs into in a much shorter period of time than what happened in the past. Still lots of work needs to be done on, but the nice thing is that the more and more ECGs we get fed into that, the smarter the AI systems get about discerning the condition of interest or not. And so in addition to HCM, atrial fibrillation can be predicted ahead of time. A drop in ejection fraction can be predicted ahead of time. And so there's lots of things that can be done. And so I think the era of data will make this happen faster.
So we're talking about diagnosis and predictive value, which can be game changing on so many levels,
yeah,
but still probably won't get us to zero risk assessment. Like, I don't think we're never going to get to 100% perfection.
Right.
They're man-made devices. If women made things, maybe it'd be different. Only kidding. We've been doing a lot of these. Occasionally I got to throw a joke in. It just works. So when we're talking about the AI thing, actually, Jeff and Steve, Brian, I don't know if you're interested in the topic as well, but we can convene offline and I can tell you what this other project is and maybe get you guys to get involved there, because it's really cool. They're taking it at a whole other level, which I think would be really great. Okay, how long can this stay involved? We've got that answer done. So let's go to Mavacampton. Let's talk about myosin modulators, cardioenergetics. Why are they starting with obstructive HCM? And do you guys see a role for non-obstructive physiology with myosin inhibitors?
So I think that this is an area that is really important. I thoroughly believe that our treatment options, as Brian nicely outlined in his talk, when we get highly symptomatic patients with non-obstructive disease, quite limited. And we have thoughts that Mavacampton can affect, cellular array, that there are things that may be beneficial to patients with non-obstructive disease. But there is some things to think about as we think about how we would design a trial or how we would look at that, because we also know that Mavacampton has a negative contractility effect. When we look at these patients, we're looking at these hyperdynamic patients and the ejection fraction falls, which is a good thing from our standpoint. But if we start with a non-obstructive patient who is non-obstructive and perhaps has a borderline ejection fraction, or a patient with burnout where their ejection fraction has fallen and they're acting more like a dilated cardiomyopathy, and the problem is diastolic dysfunction as that occurs, then I think we really have to exercise caution in a drug that we've seen lowers contractile function. It's not saying that that's bad. It's just saying that we need to make sure we tailor that therapy and design trials to really think about what patients we're treating based on what we know about the drug.
I want to stay on that for a second and get your input on this. So some of the data that was presented earlier this year at ESC showed something that caught my eye and I'm a little concerned about. And that is, I think 2 of the patients dropped out their EF to an area where they had to stop, wash out the drug. One started again and they did all right. But we have a powerful drug that can drop out ejection fraction, looking almost like a stress cardiomyopathy in the heart. Why do we think that happens? And is that something that we might see more of in a larger patient population, or were they really just quirks?
Yeah, it's one of the reasons that in this VALOR trial that we discussed, where we're having more symptomatic patients, that we really are taking care to closely monitor. I'll tell you, it makes logistics of performing the study more difficult because patients need to come back and get checked. But it's something that's really important that we understand, that we need to make sure that we're monitoring ejection fraction. And VALOR has some hard stop gaps where if there's a reduced ejection fraction below a certain cutoff, that then the drug is stopped and that's reported. So we're learning more about this. The data that was presented was a phase 3 trial, so it's a bigger trial, but it's one of the things that we're studying and understanding. And it's the reason why we don't just rush a drug straight out, because we want to understand in different patient groups, what things do we need to monitor for. And I can tell you that the ejection fraction reduction is certainly something that is on our minds and something that we want to make sure we're monitoring for.
Yeah, I just would double down on that. I mean, it was actually 10% of the patients in that trial had their ejection fraction fall to less than 50%. And it probably is due to the potent mechanism of action of the drug at the cellular level, but we don't know what the ramifications of that are. And that trial was only 30 weeks long. So, if you're talking about starting a drug on a patient, maybe in theory for life, we want to make sure we understand the safety. So that's why, I'm super excited by all the other research that's going on. And all the investigators are approaching it the right way. But I think that we also need to make sure that we don't, as excited as we are to have a new treatment option in HCM, that we don't jump in with both feet before we know that the water's safe.
I'm reminded of a statement from somebody you all know very well. I believe his name is Rick Nishimura. And it was in the dual chamber pacing, then to alcohol ablation, and the term unbridled enthusiasm was used quite a bit back then.
Yep.
And I think we need to rekindle that and not go to unbridled enthusiasm, but be cautiously optimistic that we are on the right pathway, and it's going to take time to figure out dosing and patient selection and understanding long-term side effects. And then we get to talk about the other stuff that we really have to worry about at the HCMA, and that is cost and availability and pricing and international availability and drug quality. Yep. So there's all of these other pieces of the puzzle when a drug is coming into, a new space like this. This is not, a vamped up beta blocker. This is new. This is like, this didn't exist before this. And it's been a while since we've had a drug for, well, we've never had a drug for us. We've always stolen from everybody else. So thank you to everybody else, but we've stolen from them. We're going to have our own and another tool in a toolbox. And it's going to be there with surgery and ablation and devices and other meds and lifestyle modifications. It's all going to be there. It's not going to be the miracle drug. I don't want anybody to think that. And I think some people were starting to believe that that was going to be the case. And I don't think there's any such thing personally. Agree, disagree?
Another tool in the toolkit. I think you said it really elegantly.
Okay.
Learn more.
We got it. We got to keep learning. So Jay, there's a question from Jay here. He wants to know if he can be a candidate for the Mavacampton trial. I don't know. We really can't comment on an individual case right now. That's very complex. I will tell you that there is recruitment sites that are opening up. COVID's going to make things a little bit interesting. The HCMA is working with Myocardia BMS to help in recruitment for patients who might not know from their center, because everybody's stressed out now. We're going to be offering a survey-based initiative. If you're an existing patient at a program, we will help make that pathway to let the center know you're interested. If you're not an existing patient in a particular program, we are going to give you a pathway to become a patient at those programs, and then you can discuss what's the next best step for you there. So stay in touch with us or stay in touch with clinicaltrials.gov. You can use the HCMA website. We have a portal that's called Antidote. You put in your bio, you put in your information. It tells you what clinical trials are available near you. So use the tool, and hopefully we can get more people involved in the study. Jay, I can't give your entire clinical profile here that you posted. If you'd like to contact the office and we can help you get the communication with the center of your choice, we're happy to do that, but we can't really go into your whole echo report here. I'm sure you can understand why. What are the long-term outcomes with folks who need myectomy and maze, a concomitant maze? What is a maze, for those who don't know what a maze procedure is, and when do you do them?
Brian, you want it, or you want me to take it?
Yeah, sure. The traditional maze is a surgical procedure, cut and sew. We don't really do that anymore now. It's a radio frequency ablation. It's done intraoperatively with probes to create micro scars in the upper chambers of the heart that can reduce recurrence of atrial fibrillation. In terms of long-term outcomes, I think it's been shown that surgical maze and surgical radiofrequency ablation is a really good option for preventing recurrence of atrial fibrillation. Maybe a little bit better than catheter-based techniques because deeper scars can be made at the time. But I don't know that there's been any, I'm not aware of any head-to-head studies that have been done. But oftentimes, occasionally these patients come back and we have drug treatment options we can offer in conjunction with our heart rhythm experts. Drug therapy, additional catheter ablation options may be a treatment option.
Yeah, usually what I tell patients is that the combining myectomy with maze will surely reduce the amount of atrial fibrillation you have. Maybe eliminate it, but that's not the promise we make. It'll make you have less episodes, and those episodes will be more tolerable if you have the combination of the two. So that's the usual way I put it. And yes, it is slightly better success rate than catheter-based ablation in the studies we've done here. So.
And symptomatically, patients do seem to be better than catheter-based when they have a surgical maze.
If they fail a maze procedure, can they move along to an alternative therapeutic pathway for atrial fibrillation, a catheter ablation?
Yep.
Yes.
Yes.
Okay, I have an interesting question, and I'm going to start it with, no, it doesn't work that way, but you guys can weigh in. Can digoxin be given with Mavacampton to help bring the ejection fraction up?
Yeah,
Oh.
I would. We generally don't use digoxin much in hypertrophic cardiomyopathy because it's sort of directly anti-Mavacampton in terms of digoxin in theory increases the contractility, the exact thing we're trying not to do in people that have obstruction. So I never like setting patients on pathways where I'm going to have to use multiple drugs to counteract each other's side effects. I agree with Lisa's summary statement.
Yeah, I can't think of a scenario when I would use those two drugs together.
It's an interesting question, though. Good thinking.
Yeah.
Bring it up, bring it down. It's kind of like a depressant and speed at the same time. I told you I have to throw a joke in every once in a while. It keeps me sane. Okay, we're gonna get to some COVID stuff in just a minute. So we'll get there in just a minute. So hang in there, guys. You got some amazing questions tonight. So thank you for this. Shannon, I'm gonna kind of take this question. When is it appropriate to ask your local cardiologist for a referral to Mayo or any center of excellence? You are the consumer of healthcare and you are the patient. Your insurance company may require you to get a referral if you have a certain type of insurance plan. In those cases, you must ask for a referral. Those plans are becoming less and less popular, those old HMO type plans. If you are not in an HMO, you may self-refer to Mayo or any one of the centers of excellence where your insurance is covered. Obviously, you can do a cash pay if you want. That tends to get a little expensive. So you want to stick in your insurance network. So if Mayo isn't in your insurance network and Cleveland or Tufts or NYU is, and you can get there, great. If Mayo is in your program and the other programs aren't, and you can't get to them, go to Mayo. Use your insurance as your guide, use the Center of Excellence listing as a guide, but you can make those referrals yourself as long as your insurance company isn't going to give you a financial disincentive to doing so. So that's that one. And I answer that, done.
So in regards to that one, anytime your local cardiologist is involved and can help expedite sending records and images, that's super helpful for us and certainly can help us avoid unnecessary repetition of testing when possible. So we always try to look through that information and outside records with the planning for your actual face-to-face visit. So I think your point was good on that one, Lisa.
I'd also like to tell you, put a pin in this one. I have a project that might be able to aid in the getting the electronic records to you guys.
Fabulous.
Patient's control. So we need to talk about that offline and see if we can work with some technology to make that happen. I have a really cool provider wanting to work on that. What other experimental drugs are underway? Are there any other clinical trials around the corner? I know some of this stuff, and unfortunately there's a couple things that are going on that I'm not permitted to speak about yet, but there are some things coming. Does anybody want to say anything about anything?
Nothing that's nearly as far along as Mavacampton. That's really, I think, what we're seeing as coming close enough to be in clinical use and things. I think that hopefully this will spark other novel therapeutics, but I think none that are as close to clinical use.
So we've had a couple of validations of the women delayed a diagnosis and comments on that. So thank you to those. Mayo experience, what percentage of patients are non-obstructed apicals? Are drug companies going to address this, or is the market simply too small?
Well, about a quarter of our patients don't have obstruction, but as was mentioned before, Mavacampton is being studied in non-obstructive patients as well. So drug companies are interested, and I actually think that if it works in non-obstructive HCM patients, I think that's where some of the drug companies see benefit, because then it can be extended to other people who have what they call diastolic heart failure, or when it's not that the heart muscle doesn't squeeze well, so that it doesn't relax well. So if Mavacampton or any other agent works for HCM patients who have such thick hearts, then they have hope that it's going to be able to extend it to a much larger population of patients. So
we're a good sandbox.
Yep.
To prove concept, and hopefully this data can be extrapolated to be used in patients who have other forms of diastolic dysfunction. So I think there's very much interest there, and there's a couple of other drug companies that are looking at that. There is a trial in Entresto. You can find that on clinicaltrials.gov. I don't know how successful that's going to be for HCM, but it does seem to be, a stop in the journey towards transplant for some people. So who knows? Are non-obstructeds more likely to develop end-stage heart failure from HCM than their obstructed counterparts? Pre-myectomy obstructed counterparts, I'll say.
You know, it's probably feels like that, because what we see are the patients who have non-obstructive disease, who have severe symptoms, are the ones that get referred to us a lot. And because we don't have as many tools to treat them with, then it's a shorter path to transplant for someone who doesn't have obstruction. You can't do this major procedure to relieve most of that. Now, the apical myectomy that Brian talked about was developed specifically for those set of patients who were like, well, should we try this and try to, you know, have their heart relax better if there's less heart muscle, versus just giving them someone else's heart and giving all the donor issues and those kind of things. And it again has worked very well, but there's only a couple of surgeons in the world that do that procedure, so that's not the major path to success for everybody.
Correct.
I think one other thing is that obstruction and non-obstruction may be a continuum.
Yeah.
You may have someone who in teenage years is very thick and hyperdynamic and has obstruction, but as the person and the heart ages, that obstructive physiology can transition into more diastolic dysfunction, more problems instead of with the squeeze, with the relax. And we can see that someone who initially was obstructive is now non-obstructive and then ends up requiring transplant. So would you count that as obstructive or non-obstructive? It's kind of, I don't know, it's a continuum.
I've been both, and I got rid of her. She's in the box back there. So I think there's a lot of focus on dealing with obstruction and medications focusing on obstruction because it's, you know, it's the biggest gorilla in the room at the moment. And once we maybe get past that a little bit more and clear up where this drug is used for obstructions, similar to Norpace. Norpace works really well on obstruction. It's just hard to get it because Pfizer's not making it right now, but it works. I'd love to see a head-to-head Mavacampton versus Norpace because I think there's going to be a big price difference between the two, and we need to see how that balances out as well. And in part, this is kind of our role at the HCMA to kind of push these questions out there so patients don't have to go broke to feel better. We might be able to find some happy medium for some other people. Do we think that early adoption of medication in genetically positive children can curb, limit, or stop hypertrophy? And what trials have been done there?
I'm not aware of trials that have been done in the pediatric population. It's been studied, I believe it was losartan, is that right, Steve, that was studied in the adult population, but unfortunately.
And diltiazem has been studied in children as well. So the DELIGHT trial looked at children. So I mean, I think there is hope that if you intervene on a normal thickness heart early on, that we could prevent some of the consequences down the road. But the early trials were modest.
Yeah, there wasn't a lot there. And I know a number of families had a hard time giving their child a pill for a maybe. So the threshold for an adult to make a decision to participate in a clinical trial is one set of decision making. To bring your child in is another, and there's a lot of emotional baggage that goes along with that for the parents. I'm going to come up with a few more questions, and then we're going to stop Facebook streaming and stop recording. I learned a lot this evening. I know Mayo publishes a newsletter. Does the HCM clinic have similar things for news and announcements? We've just updated the HCMA newsletter. We were hoping that we might next year reach out to our research partners and our Center of Excellence partners for a more formal communication. We've got some big stuff coming up for January that we're going to be doing some strategic planning with. And, you know, Steve's going to be getting an email from me saying, come on, we need you for a meeting to discuss the future. And these are some of the questions that we're going to be bringing up. How can we work together to get information out in a more systematic, uniformed way so the entire community is staying informed every step of the way? So we're trying.
There is a HCM Mayo Clinic Facebook page also. So that's there's a lot of discussion that goes on there. A lot of the things that came up tonight, there's a lot of discussion going on there. It stays pretty lively. Sometimes it's specific to Mayo Clinic care and episodes of care and such, and sometimes it's HCM in general. So I know there's a lot of traffic out there, so that might be something to look forward to too.
Yeah, they're talking about news from the center as opposed to conversation, I think was the way the question was worded. So
Okay,
we're,
great.
all communication is good. All communication is very good. Can we discuss, and then we're going to go to COVID after this, anxiety and HCM? Is it the cat chasing its tail, or is it the tail chasing its cat? What's HCM, what's anxiety, and how the hell do you figure the two apart?
And I don't think that anxiety is linked in a causal relationship with HCM, other than the fact that you've just been told you have this multi-syllable diagnosis having to do with your heart, and it is human nature to get anxious about that. Think about a number of patients who get picked up because their family has this. They were asymptomatic until they got diagnosed. And with 6 months, many of those patients are now recognizing they have symptoms because they're paying attention to things more than they did before and worrying about what's going to happen. And actually, that's one of the major things that we do with the HCM centers is help you, walk away from the edge a bit and recognize that HCM can be completely compatible with a healthy lifestyle and normal longevity. And we don't have to do worst case scenario thinking on everything, but it's human nature to do that. And so that's one of the things that we do when you get to talk to someone who sees this every day, to have those reassuring words and conversations.
I ask patients sometimes, their expectations for their visit and what their activity is on a scale of 1 to 10 and what their worry is on a scale of 1 to 10. I don't usually use the word anxiety, but how worried are you about this diagnosis at the beginning of the appointment? And then I'll ask them at the end of the appointment after we've had a long sharing decision, patient-centered care decision, in hopes that we've been able to impact that for them. And usually we can. Knowledge is power, and certainly that improves your overall worry factor as well.
There was some data out of the share registry, which was completely consistent with our experience at the HCMA, that the first 2 years of diagnosis, you feel more symptoms, you're more anxious, you're on top of everything, you're cardiac aware for that first 2 years until you realize I've been doing this my whole life and now I just know what it is, and you come to comfort zone with it, and you start to learn what your normal is. As I'd like to refer to it, is you learn how to walk on the HCM balance beam, and sometimes it's 4 foot wide and sometimes it gets a little narrower. And when it gets too narrow, you put your heart in a box. But generally speaking, you can balance this out quite well. This is another reason why we're offering different support groups on different subject matters. We're going to do a once a month newly diagnosed room and help them find their pathway to centers and do this in a much more structured fashion. As well as the pre-myectomy meetings that we're going to be doing monthly, so people can always chime in and they can go back for those new messages. And then families go through that 2-year cycle again if somebody else gets diagnosed, and then they're watching the kid for that 2 years and what's their normal. So a lot of these families go through these hills and valleys, and in a sense, it's a process of grief every time something happens. Somebody has to go for surgery. They process grief. They've lost control and they're concerned about what's going to happen next. They got to get an ICD. They process grief. They go through it again. And we're here the whole time trying to manage that and get them into the proper care models so that the burden can be a little bit less. So one last question before COVID. I know I keep promising, but Carol had a good question here. Coronary artery disease on top of hypertrophic cardiomyopathy. When do they go stent happy, angioplasty happy? When is bypass and myectomy better as an option? Is this a case-by-case decision?
Maybe I can tackle that. So in that study of 3,600 patients that we looked at, 17% of patients with HCM in that study had coronary disease. And so this is not an infrequent thing. It can play a role in decision-making if septal reduction therapy is on the table, because you may choose to pursue concomitant myectomy and coronary artery bypass grafting. But a lot of times our decision-making is made in a similar fashion to patients without hypertrophic cardiomyopathy as far as what intervention is right for the coronary arteries, whether it's stenting or bypass grafting or medical management. And it's really an individual basis that we assess that.
Okay, COVID. all things COVID. So Ackerman had to put out that paper about ACE and HCM, and everybody went, oh my God, we're all going to die from it. And I got to smack him for that because that made the phone ring an awful lot that day. How are we doing in COVID times with our HCM patients? What have you guys seen? Do you have any best advice for anybody with HCM who contracts COVID and becomes symptomatic?
Well, first of all, wash your hands, wear a mask, avoid getting COVID, first and foremost. You know, I would say that the patients that I'm aware of the patients that I see who have told me, every one of my COVID positive HCM patients managed to do so asymptomatically. So they were contact traced and had it and resolved and those kind of things. So I've had a lucky set of patients in that regard. You seriously just have to follow the local care programs where you're at, because remember, each of our cities has a different burden of COVID and different things going on, and it's hard to generalize what goes on in Rochester, Minnesota versus what's going on in Manhattan, because of just the differences in what's happening in the community. So you really just have to make sure that if you think you've got COVID, you contact your primary care team to see if you need to get tested and those kind of things, and then follow their advice, you know, to the letter of the law for that. And I do think, I saw that someone had asked before about what do we think about vaccinations. My hope is that we're all going to get vaccinated, but I do think that the nice thing is that, you know, the UK is going live now. The first tier of people to get vaccinated in the US are going to be frontline care workers, probably skilled nursing home facility patients. And by the time that those of us who are ambulatory, even if we have diagnoses, who are doing pretty well, have to face that decision, we will know whether the side effects of the second booster are severe and those kind of things. I mean, it likely will have side effects. If anyone is of a certain age and you've had the shingles vaccine, that one can make you feel pretty lousy afterwards. So it's going to have an impact, but I think that I'm going to want all my patients to get it as long as we don't learn something horrible about the vaccine causing side effects.
This most recent week, we had a grand round, and we had an ID panel of experts talking about the vaccine, and they all agreed that they would take the first vaccine that was available to them that had, of course, achieved FDA review, regardless of the manufacturer, and then they would take the boost thereafter. So I think it's with great confidence at this point that it would be highly encouraged.
And I just wanted to underscore what Steve said on the optimism and positivity. The patients that I've had with hypertrophic cardiomyopathy who contracted COVID did really, really well. Surprising.
So on a national level, I've been working with a number of people who have developed COVID and have HCM at varying different degrees. The one caution that I would ask the care providers as well as the patients is to do a check-in shortly after your recovery and see what your cardiac status is, because we did have somebody who developed some myocarditis and that made him pro-arrhythmic. So he's fine. He did okay. He did okay through COVID. It was a couple weeks later that there was some problem, and myocarditis is part of COVID, and you can have HCM and get some inflammation in the heart. So we want to make sure that you do get your heart checked after you've recovered. Do you guys have any best practices or thoughts on having a pulse ox at home, doing breathing exercises if you are COVID positive? Are there any tips or tricks? What number do you hit before you go to the ER and try to get admitted? These are the questions.
So that's why it's a little bit different in each care system. So every patient at Mayo who gets diagnosed with COVID gets sent home with a thermometer and a pulse ox. And then there's a nursing pool that you know, twice daily looks at the uploaded data on that and can intervene on that. And if they're higher risk patients, they get more equipment than just a pulse ox and a thermometer. So, but that's a Mayo specific program. And the threshold that what Mayo has what's called the COVID frontline care team. So it's the primary care and ID folks who deal with all these patients who have COVID, and their threshold for which patients have went reported based on their pulse ox is a bit of a moving target based on how hot our environment is at the moment or not. But that's why I think it's always good to be checking your pulse ox. And if you know it's always 93 or above and suddenly you're in the 80s, it's probably worth a call to your care team if you've got a pulse ox at home. But it's a standard of care that we have for our patients.
And people that have COVID, regardless of your comorbid conditions, if you're feeling well enough, you should remain active with a walking program and not spend too much time, obviously, resting or in bed. If you're feeling good, you should get some good exercise and exercise your lungs and get some good pulmonary work done if you can.
Don't panic if your pulse ox is normally 96 and you hit 94 or 92.
Don't panic. Don't panic.
It's going to fluctuate. Your body is challenged. What about remdesivir, convalescent serum? HCM patients are going to respond the same way as everybody else, we think, right now.
That's what we think.
Yeah.
Everybody wants to be special with HCM and they're like, well, won't we be different? I'm like, no, I think we're pretty much normal for this one.
Yes.
So
Agree.
we don't want to get really sick and be on a respirator because it will
Right.
be worse for our lungs, or our heart probably, but we're pretty good. Okay, I am going to stop Facebook. And we are just in the room. Oh, no, I'm sorry. And we're going to stop recording. So to those who are watching this on YouTube later on, if you have any further questions, you can contact the HCMA at support@4hcm.org or visit our website at 4hcm.org. I just said that, support@4hcm.org or the website 4hcm.org. It's getting late. And we can hook you up with any materials that you need as a follow-up, or if you want to find the directory of HCMA recognized centers of excellence, just go to the website, look at the directory, and you will find 41 amazing programs that can help you and your family. So I'm going to stop the recording and you're all going to get the